Good morning, everybody. Almost good afternoon. Sorry about the delay. We were in rules. If you are interested in rules tomorrow, bring your sleeping bags and to be comfortable, and your lunch and your dinner, because we're going to be there for a long time in the House section. Okay, let's get started. And thank you to the committee members. We have a great turnout. I appreciate that. On what could have been a day off. First, let's see, I'm going to call House Bill 279, Representative Rogers. And if everybody will look in their packets, Representative Rogers, are we working off? Have you got a copy?
Yes, ma'am.
Are we working off the substitute to 279, which would be LC 335116S? Okay, has everybody got it? All right, go ahead.
Thank you, Madam Chairman. I appreciate the opportunity, and members of the committee appreciate the opportunity to be here today and bring it before you HB 279. When I dropped the bill, someone asked me, got it? When I dropped the bill, someone asked me, what do you want to do? And I said, well, my main purpose is to stimulate some discussion, and based on the crowd today, I think I've accomplished my purpose.
Yeah, we seem to have stirred up some interest in this.
Well, and that's a good thing. That's a good thing, ma'am. This bill very simply allows independent multi-specialty physician groups the same exemption that single specialty physician groups currently have. It allows them to build their own surgery centers. They'll be subject to the same rules and conditions of Georgia law as the single specialty surgery centers, and these include a spending cap of $2.5 million and a commitment to performing indigent care and charity care and accepting Medicaid. To me, this is basically a free market issue. Allowing the same exemption for these multi-care groups that's provided to the single care would allow them to build their own surgery centers, thereby continuing to serve their patients at a significantly lower rate and lower cost than is currently incurred when they have to send them somewhere else. I appreciate the opportunity to bring the bill to you. I know that there's a lot of questions, and I'm far from an expert on the CON law, and I do appreciate the opportunity to bring it here and to have the discussion. In order to better answer your questions, I'm joined today by Mr. Victor Mondalvo, who I think is a friend to this committee and is well known here, and I believe he will have a lot of answers for some of the newer members as well as existing members of the committee. And with your permission, we'll just go ahead and ask for questions, or however you want to handle it, ma'am.
Okay, I'll ask Victor, and yes, having the scars for 2 years of the CON chairing that committee, I do know Victor and some of the players quite well. Do you have anything you'd like to add to the presentation?
Thank you, Madam Chairman. I really appreciate the opportunity to be here today and talk about this issue. Like Representative Rogers says, this is an issue that has come to the legislature on and off over the years, and things have actually changed so dramatically in healthcare today in light of all the recent changes in the law, both federally and state, over the past 4 or 5 years, that the issues have become more acute and more important to doctors in the state of Georgia. The purpose of this bill, as Representative Rogers says, is really to sort of level and balance the playing field a little bit in Georgia. As the chairwoman knows, CON's been around for about 30 years, give or take, really since the 1970s. It was adopted as a mandate of the federal government. And some of you don't know, I know you're new to the committee, so if you know this, I'm sorry to go back over the same ground. So thank you. But it was a mandate by the federal government because Medicare was paying providers based upon their cost. So the more you spent, the more you got from the federal government. So the federal government said to the states, we need you to have a CON program to limit overbuilding because we're just having to pay people to build things, and we don't want to do that. Over the years, of course, that's changed dramatically. Today, you're paid by Medicare and pretty much everybody else for the episodic care services provided. You get a flat fee per type of disease or type of service. It's not based upon your cost. It's your job as a provider to manage your costs and hopefully make a profit and cover your costs by what you get paid. So the purpose of the CON law has gone away a long time ago, but it's still in place in Georgia. About half the states have repealed it entirely. The other half still have it. Georgia's probably in the top 3 or 4 of the most regulated states, believe it or not, for CON. Georgia tends to be a free market government. It's a free market society. but this is one sort of vestige of the old sort of government in healthcare sort of role that is playing and still plays in Georgia. In 1991, the government actually, as the chairwoman knows, the government actually adopted an amendment to the CON law which allowed single specialty centers to build what they call L&R centers, or exempt surgical centers. Those are single specialty centers. You have to be a single group and a single specialty. That's been around since 1991. In 2008, during the last CON battles that the chairwoman referenced, the legislature adopted an amendment to the bill, a law which allows hospital-based joint ventures. And what that is basically is hospitals and single specialty groups can open up exempt CON centers, exempt ASC centers, as long as the hospital owns at least 30% and the doctors own at least 30%. So the only groups in the state at this point that don't have an exemption of some sort to open up exempt surgery centers are the multi-specialty groups. And what I'm talking about there is in a multi-specialty group, you'll have orthopedic, general surgery, urologists, pediatricians. So a multi-specialty meaning a wide array of specialties in one group, and they serve as one group. Independent Doctors of Georgia, who I represent, Harbin Clinic up in Rome, South Coast in Savannah, and Longstreet in Gainesville are great examples. They've been around for decades. They provide tons of Medicaid and tons of indigent care to patients, both for their ancillary services and for their primary care and surgical services. And they need to be in a position to have the same or level the playing field a little bit in light of what's going on in the market today. As you probably know, and you read it in the newspaper all the time, hospitals have gotten into the business of actually buying and employing physicians. So years and years ago, when CON was first adopted, hospitals had a discrete role, doctors had a discrete role, and everyone worked together for the common good. Today, and it's really nobody's fault. It's basically the marketplace today. There's lots of pressure to consolidate for efficiencies and reduce costs. And what hospitals have done, again, this is just part of the marketplace. They've gone out and purchased practices, and they've hired doctors. And in fact, in some communities where doctors won't sell, the hospitals will recruit and hire doctors to compete with the independent doctors. So the hospitals themselves have become very large multi-specialty groups at this point. And so they're multi-specialty groups where they refer to each other, they refer to the hospitals, and the independent doctors are basically sort of left on the sidelines trying to figure out how to continue to do what they do and continue to serve their patients. This bill does not fix that entire problem. It's not meant to do that. That's a whole other debate. What this bill does is simply allow them to open up exempt surgery centers for their own patients. They're subject to the same requirements as everybody else. They have to do indigent. They have to do Medicaid. They're capped, right now they're capped at, it's like $2.5 million, give or take, to build them out. So you can't even build a very large one if you want to build one. So generally that's one OR, maybe two ORs. And for the most part, what these centers do are low-risk outpatient surgeries. And keep in mind that all outpatient surgeries are deemed to be elective. So if it's outpatient, by definition, it's elective, so it's not a mandated type of environment. You're not required to do these surgeries. Most people need these surgeries, even though they're outpatient. It's not a matter of that. It's not elective to the patient, but it's elective in terms of how the medical community looks at them. So all this bill would do is allow, again, multi-specialty groups to open up exempt surgical centers that would be only for their own patients. They would be subject to the same cap as everybody else, and they would have to do indigent and Medicaid. And again, in light of the way the market has changed over the past really 5 or 6 years, independent groups, particularly in the cities we're talking about, the larger urban areas, need to be able to compete with really hospital-based physicians who are basically referring to each other, referring to the hospitals. And what this bill does is help, again, just to balance that a little bit. It doesn't try to correct the problem entirely, but the bill will allow at least these groups to level the playing field a little bit. So that's why we're very appreciative of Representative Rogers' willingness to speak today and support the bill, and that's what the bill does. I do want to point out that I was asked if I had something that I wanted you guys to see during my presentation. I handed out an article from the Wall Street Journal. This was actually mailed to all the members previously. We brought extra copies today to talk about.
Are they passing them out?
I've got extra. I think there's extra copies in the back there.
I don't.
They were passing them out, but we did not pass them out. We're waiting for a special.
Oh, okay. I didn't get. Okay. Okay.
So what you'll see is you've seen this before, I think. It basically talks about Same doctor visit, double the cost. Insurers say rates can surge after hospitals buy private physician practices. Medicare spending rises too. And again, what this is really talking about the movement across the country, really, not just in Georgia, where hospitals are acquiring physician practices. And if I was them, I'd probably do the same thing. It's not a condemnation of their actions, but basically because of the market share problem, once they start acquiring practices, there tends to be an increase in costs. Hospital charges tend to be higher than private physicians. The referral in their system goes back to the hospital, not to maybe the lower cost private physician practice. And what this bill talks about is the fact that that's what's going on in the marketplace today. Again, because of the market problem and the market leverage that the large groups really have in the state, it puts the independent groups at a disadvantage. And so what the bill does is, again, try to address that problem where it allows independent groups to continue to compete, but it also is better for the state of Georgia. For Medicaid, it's cheaper to do services at outpatient, freestanding, independent physician-owned surgery centers. Insurers like it because it's cheaper to do the same exact procedure at a freestanding surgery center as opposed to a hospital. And that's just the way the cost reimbursement is. Again, nobody's fault. This is not to say there's a blame game going on. Hospitals just get to charge more for a procedure. That's always been that way because they have a lot bigger overhead, lots of other things that they provide, while the smaller centers charge less. It's better for the patient who pays the copay. It's cheaper for me to go to an outpatient surgery center because I got to pay my copay. I'm on a high deductible plan myself, so I've got to come out of pocket a bunch of money. And so it's better in terms of for the citizens of Georgia, it's better for the state, for the Medicaid program, it's better for the state health benefit plan because those folks, again, it's coming out of state coffers to cover those folks. And that's what this does. One of the incidental benefits of the bill, it helps deal with costs and help keep costs lower than they need to be. Again, thank you very much, Madam Chairman.
Okay, I have the first question because we'll open it up for questions for the representative and Victor. You're saying it's lower cost. Are you telling me that the insurance plans and that the Medicaid and everybody pays less to these centers in reimbursement than they do to hospitals? Hospitals get a higher reimbursement
Yes, ma'am.
for the same procedure?
Same exact procedure. And I think Dr. Reinhardt from Longstreet brought with, and I didn't realize this, he was going to talk about it when he discusses it this morning. For a colonoscopy, the same exact procedure, you get paid less. You being the facility, hospital or surgery center, gets a lower charge, get lower payment for the same exact procedure. That's absolutely correct.
Okay. Questions? Light up your lights, guys. Representative Rogers.
Thank you, Madam Chair. Doctor, I want to ask a few questions to you. You kept mentioning hospitalists. Do you feel like as a practicing practitioner?
I'm not a doctor, but I can.
Oh, I thought you were.
He did stay at the Holiday Inn Express last night.
Okay.
I play one occasionally.
What are you then?
I'm an attorney.
Oh, you're an attorney.
Yes,
okay. Well, I don't want you to operate on me then.
You wouldn't want that.
Ooh, I don't think so. He's really,
There are physicians who will.
It was a long day yesterday and last night. I'm sorry.
That's fine.
And I'm Carl Rogers, not Terry Rogers, too. In fact, I want everybody to know that.
Especially today, right?
Well, off session. Since, do you feel like the hospitals are gaming on the physicians? As far, I guess, as an attorney view, are you hearing that all the time as far as the hospitalist issue?
Yeah, I don't know. I don't want to accuse anybody of gaming. Again, I don't want to blame anybody. I think the marketplace, the way the marketplace is today, and again, if I'm the hospital in a community and I want to control the referral pattern, I'm going to buy physicians. And so what happens with, and again, it's just a marketplace issue. If I'm in a position to acquire a doctor and direct that he refers patients to my hospital or my other owned or hospitalist physicians, then that's what happens. And as a result, the independent doctors get left out of that referral pattern. It varies by community. Some communities are very aggressive. Some don't have a lot of this going on. But I can tell you in Atlanta, it is very aggressive. And in some other communities in the state of Georgia, absolutely very aggressive. Some of the doctors I represent have been approached by 3 separate groups, hospitals in Atlanta. You probably know who they are. All 3 of them put a bid in because they want to capture the referral pattern and get those guys into their doors and make them hospitalists. So as a result of that, the market's getting smaller and smaller for the independent groups as a result of that competition. And what's sort of disturbing, I think, and I'll let the doctors really address this themselves, the doctors, what happens is that these Harbin, Longstreet, South Coast have been providing services in their community for decades. And because they don't want to sell out, they want to be independent, they think it's better for the patients and better for this consumer to be independent, the hospitals in some of these communities, again, not all, will actually recruit doctors doing the same exact thing as the independent doctors because they control the referral pattern better by having that employed physician. I'm not saying that's right or wrong, but that's a fact, not just in Georgia, but really all over the country.
Follow-up question, if I may, Madam Chair.
Yes, go ahead.
You say it will lower the cost of insurance. I thought you said that.
I didn't say it lowers the cost of insurance. I say that the insurance companies pay less to freestanding surgical centers than they do to hospitals for the same exact procedure. And Medicare absolutely does that.
So reimbursement rate's higher on the hospital side,
Yes,
is what
sir.
you're saying.
Yes,
How
sir.
much higher is it?
It varies. It ranges from anywhere from 35 to 65% higher depending on the procedure.
Is the same issue as far as hospitals are concerned? If they're employed by a hospital, they get a higher reimbursement rate other than a private practice?
Yeah, not to get into the weeds too much, but you've got a professional fee, which is the doctor charge, and then you have the facility fee, which is the hospital and surgery center charge. So when I'm talking about the 65 to 35% increase, I'm talking about the facility fee itself. The doctor fees generally are going to be the same. So the doctor who's employed by the hospital will get paid the same, or his boss will, the same professional fee, whatever the doctor does. So when I'm talking about the difference between the 35 and 65%, it's what we call the facility or the building fee.
Okay. And one further question, Madam Chair.
Okay.
If the only place you can get a procedure done is in a county is at a hospital, what assurances do patients have that price and quality are good?
You know,
Of course, you're not a doctor, so
yeah,
you
I
may.
can tell you that competition is good. I think that when you have a one-horse town, the guy that owns the horse gets to charge a lot more than if you have a two-horse town and you guys are bidding against each other. So I think that you know, quality is really generated by licensing and the quality of the physician. CON really does not address, in my opinion, the quality of the doctor or the quality of the facility. That's a licensing, accreditation. There's lots of things you can do to show your quality. But in terms of competition, yeah, you know, CON clearly is a competition limiting law. That was the intent of it when it was adopted, and it's still true today.
Okay. One more question, and I'll finish, Madam Chair.
Okay.
Do y'all plan, would you like to open your own emergency rooms? I know we have, where I live, we're the third busiest emergency room in Georgia. Is that the goal for these multi-specialty clinics to be in the emergency room business too?
No, the ER bill, I'm aware it's on the docket today. That is, no, what I'm talking about is a surgery center, true surgery center.
Yeah, but I'm talking
not
about
the
down the road. Do
No.
you see that happening?
No.
Not in your lifetime, not in my
Well,
lifetime?
not from the physician side of it, no. I mean, I can see some hospitals wanting to open up their own freestanding ERs, and I think they've actually filed some with the state of Georgia that have been denied recently, but those are hospitals themselves applying for freestanding ERs, not doctor groups.
Okay. Thank you.
Representative Rogers, I have people that have come and approached me and talked about freestanding. Yeah, I'm talking to you, Carl. And the committee. We have had people that have come to the office to talk about freestanding emergency rooms before. Okay, Representative Morgan.
Madam Chair, thank you for your presentation. So my question is about hospitals, and so I wonder if you could respond to the concern that if these standalone centers are created, that it would take away private pay or insured the patient base, and then leave just Medicaid patients or indigent patients to the hospitals, and then of course having an overall impact on the hospital. Can you respond to that concern?
Sure, and I think that's a legitimate concern. When the law was amended in 2008, all freestanding surgery centers that are physician-owned, what we're calling physician-owned single specialties, are required to do Medicaid and indigent. That's a requirement. If you want to open one, you've got to do it. Even though these centers are for-profit, they're not for-profit. They're for-profit entities who pay taxes to the state government, who pay taxes to the state government for a Medicaid program. They're required to commit to either do 2% indigent and Medicaid, or 4% indigent if they don't want to do Medicaid. So that was actually discussed to try to deal with that issue back in 2008. So these centers would be subject to the same exact requirements. I will also tell you that The large multi-specialty groups today do a lot of Medicaid and indigent in their practice, in their ancillaries or imaging and other non-surgical ancillaries. They do tons of Medicaid and indigent. And in fact, you may know this already, but when a hospital talks about providing indigent and Medicaid services, the only people who are licensed in Georgia to provide medical services are doctors. So when a hospital says they have to provide indigent and Medicaid, and they do a lot of it, they're talking about their facility fees. When we're talking about the doctor who's in the facility, and the doctors can answer this themselves, they're here today. When the doctor comes in and provides services for Medicaid or indigent, particularly indigent, lots of times he gets nothing. And he doesn't get paid at all, but he's still providing the service. And again, you can ask the doctors this question. And these doctors do this because it's their community. They know these people. And so, I've heard that before about, well, are you going to steal all the good-paying patients? That's a little bit insulting. These doctors, are not out there trying to steal everybody's money. In fact, the only reason we're here today is because things have happened in the marketplace. Again, not a blame game. That basically where the hospitals are out there buying practices and hiring physicians and taking the market share away from the independent groups who have traditionally and have always provided Medicaid and indigent to their community and at the hospital. So I'm long-winded, but yes, absolutely, we don't believe it's going to be a problem when we address that.
Thank you.
Thank you.
Okay, thank you. Representative Hatchett.
Thank you, Madam Chair. Kind of answered my question there, but along with the indigent percentages and Medicaid percentages, do you know actual percentages, and somebody maybe can address this later, but like what percentages hospitals do, what percentage some of these ambulatory centers have done?
Sure. I don't know off the top of my head. I can tell you that information, that's the public information when you look at the state database. Most of the hospitals in Georgia are not-for-profit hospitals. There are some for-profit. But most of them are not-for-profit. And when you look at the database that the state has, their indigent care, and this is for all services, not just for surgery, which is what we're talking about, but for anything else that they do, whether it's trauma, neonatal, whatever else that they provide in the hospital, it ranges from a low of like 2% to a high grade of 25%. The average is somewhere between 7 and 8% based upon state data. Again, these definitions are sort of funky, whether the way the state defines adjusted gross revenue, and they're different than how you file your taxes. But that's generally sort of the number that the state seems to have. When you, until 2008, the freestanding surgery centers didn't have any commitment. They didn't have to report what they did. So that data is actually pretty thin right now. But that's why the law requires that surgery centers do indigent and Medicaid in order to deal with that issue. I also do want to point out that the not-for-profit status is not a small thing. If you're not-for-profit, remember when you start looking, I'm not an accountant, but when you look at the math and you say, okay, I'm a not-for-profit, I don't have to pay taxes. So when I provide this indigent and charity care, that's part of my community benefit. That's part of my mission as a not-for-profit. So the law is pretty unusual where actually the law, and we're not complaining about it, and it's fine, the law imposes on for-profit entities the requirement to do indigent and Medicaid. So, and that's perfectly fine. That's been the law in 2000, was adopted in 2008. It's the law today. It will be the law if you adopt this amendment today for the multi-specialty center. So, so it's a little bit apples to oranges comparison, but that's, hopefully I answered it to some extent. So
you said some of these surgery centers had done a lot of Medicaid indigent care. You're not sure what those percentages are.
Right. You didn't have to report it till starting in 2009, 2010, and so it's not particularly clear what that information is. But I can tell you that when you talk to the doctors today who will talk to you on behalf of Longstreet and Harbin and South Coast, they will tell you that they do a lot of Medicaid and indigent in their practices. Again, not just for the physician services, but the ancillaries like imaging and other things that are not physician services. They do the same mix of Medicaid and indigent for them. They could send all those to the hospital and somebody else as well. They don't do that, and there's no reason to believe they'll do that today. So.
Representative Hatchett, you through?
Thank you.
Representative Clark.
Thank you, Madam Chair. Representative Rogers, thank you for coming before us today with this bill. Got a couple. What was your name? I apologize again.
Victor Moldovan.
Victor Moldovan.
Yes, sir.
I have two questions, if I may, Madam Chair. The first has already kind of been covered, but I guess why, as I've been talking to the folks on the ropes who oppose this bill and support the con laws as they are, just maybe you could help me understand why do when I ask the question about competition, would that help us to reduce the price of health care and all, and some of the article we have here from the Wall Street that was interesting when I read last year. And as they were addressing the question, I keep hearing that you guys that the independent surgical centers aren't providing indigent care and Medicaid, and that it's unfair. So if you could, I'll go ahead, if I may, go ahead and mention the second question. Maybe you can address it at the same time. Why do I keep hearing that over and over? And if in fact they are providing this care, then how do they compete? We're very proud of, in my community, Gwinnett Medical Center in Northeast Georgia and their new satellite campus, and I appreciate all they do for our community. But my question is, if independent surgical centers are providing this care, indigent care, how do they compete then? It seems that they would be perhaps at a disadvantage, if you could help me understand, with all the benefits we give these hospitals, because again, we are proud of what Gwinnett Medical does for our community. They have a lot of tax breaks and other incentives. How would y'all compete with that?
I think that's a great question, and I think and that sort of indicates the dynamic and the evolving nature of healthcare in our country over the past really decade. And so to sort of address the first question, competition is good. Competition does lower costs. Medicare obviously sets rates, and that's what you get. But insurers certainly look for competition among providers. They look for competition among doctors. The dynamic of competition is the same in healthcare as it is for every other industry. Now it's a little bit different because you do have insurers or sort of the middleman, and Medicare is involved. But at the end of the day, we're paying co-pays as well. So if I can pay less to somebody else to get the same exact service with the same quality, I'm going to do that because I got to pay out of my pocket for a lot of it. So in the context of competition, I think competition is important and it's good and it does lower costs. In terms of freestanding surgery centers, that was the complaint back in 2008 that the hospitals had about, well, it's not fair because these single specialty centers don't have to do indigent and Medicaid, and we don't think they're doing enough of it, which is why the law was amended in 2008 to require them to do indigent and Medicaid, and which was why we're saying today that we're not asking that be changed, that the multi-specialty centers be subject to the same requirements, do indigent and Medicaid. In terms of competition, I think that's a great question. In fact, if you're a for-profit competing against a not-for-profit, it is actually that is a dynamic that you have to consider when you do your pro forma, that you're competing against the facility that is not-for-profit, that gets lots of tax breaks and incentives, not just in income tax, but real estate taxes and lots of other incentives to be a not-for-profit. But that's the trade-off that those guys make. They say, we want to be not-for-profit, we want to provide a community benefit, our mission is to provide services to the community. So since they're willing to do that, maybe they should get those benefits. They should say, yes, I should get that benefit and be not-for-profit because I'm obligating myself to providing a community benefit. For the for-profit side of it, the surgery centers, my clients, for example, they have to consider that going forward. But even with the imposition of the 2% or 4% in Medicaid, they'll be required to manage their costs. They'll manage their costs to make sure that they can cover their costs and provide good services to patients. It's really no different than any other business. You look at what you're going to get. You have to obviously design your budget based upon what you plan to get. You know that your competition has a not-for-profit status and you don't. Nonetheless, I think that's going to be an opportunity for them to be able to provide these services at a cheaper cost. And because it costs less to actually do what we're talking about in a freestanding surgery center, the rates can be lower and you can actually cover your costs and do fine. So I think it'll be interesting to see, but I don't think it's going to have a dramatic impact that they won't be able to compete. I think they will.
Representative Hawkins.
My questions have been asked.
Okay, thank you. Representative Howard.
My question has been asked, but I would like to ask, are we going to have some testimony from the opposing side?
Sure.
Yeah, all right, thank you.
Sure. Yeah, we're not one-sided in here. That would make it very uninteresting. Okay. Representative Stevenson, who knows a lot about Grady.
Well, thank you, Madam Chair. It seems like last year that we were just doing this CON committee.
Right.
But I want to make sure that we understand this competition amongst the physicians first, because you described the hospitalists, and I believe that it was Lisa's response that, and I don't want it to be confused with the physicians whose practice were acquired by hospitals. They're different, correct?
Yes and no. If you're a clinic and you're acquired by a hospital, you become an employed physician of the hospital, and you may not be a hospitalist where you're sitting in the hospital all day, but you're an employed physician who's employed by the hospital, maybe in an office off the hospital site. So correct. So hospitalist technically means you're in the hospital, that's all you do all day, as opposed to being a hospital employee in another office.
Right, so that's one category.
Yes.
So the other is the hospital purchase physician practice, could be off campus, could be in their same office,
Yes, ma'am.
correct?
Yes.
And then you have the independent physicians that you've named independent. Okay. So that the competition you're describing is between those physicians who are independent versus those that have been purchased by the hospital.
Yes.
Right. So my question is then, when you talk about competition, those purchase practices would have already been independent at one time, right?
Yes, ma'am.
And they come with their market share. And the independent hospital physicians have their market share. So that competition is not really being changed.
Actually,
is it?
it is. And
Okay, how so?
Here how it works is that if I'm a hospital and I have no physicians on, no employed physicians, and I decide that I want to get into the physician business, I start buying specialties. I buy an orthopedic surgeon, and I buy a ENT, and I buy a primary care guy. Then all of a sudden I've created a physician multi-specialty clinic that I own, while the orthopedic guy may have referred business to an independent doctor before. He's now basically going to refer to the hospital employed physicians. So over time what happens is that the referral base gets smaller and smaller, and the market gets smaller and smaller for the independent doctors, while the hospital who's acquiring these practices and employing physicians gets bigger and bigger, because they're basically, all these guys used to refer to each other in the community. Now they're actually, and there's nothing illegal about it. I want to make clear that this is just a market issue. That they're basically referring now to each other. So they've created, in some communities we have hospital, they're basically multi-specialty physician clinics with a hospital.
May I ask a couple more questions? Well, given that scenario, because you would agree with me that most the hospital practices that have been, the physician practices that have been acquired, they already had admitting privileges at the hospital, correct?
That's true, yeah.
Well, then, and the referral base is not mandated by physicians.
Well, under the employment contracts that I've seen and I'm aware of, the hospitals actually, if they employ a doctor, they require them to refer if possible within their network.
Right, but if possible.
Yes.
Right. Okay. So then the competition between the hospitals is not, there isn't a nexus between that and the ability to manage the surgery, because both admit to the hospital, both can admit patients based on scheduling to the hospital, correct?
Yes.
Okay. Then back to the cost, you've already answered the question regarding the difference, and that's the facility fee that a physician with the name AmSurg Center can add. So if you were to add the cost of the facility fees with the physician fees, even in the single specialty, are they not like similar costs?
No. No, because the facility fee is so much less in a surgery center, it's going to be a lot less overall, even if you add in the professional fee.
Meaning that the facility fee is determined by the overhead costs, meaning the equipment and one.
Not really. I mean, they're
Really?
based
You don't
upon
think so?
DRGs now, and basically you get a flat fee. And well, I guess maybe they come up with it that way.
Yeah,
but
that's
you
the
know,
method, isn't it?
Right. They basically
Okay.
say this is what you're going to
Okay.
get paid.
My last question is on this multi-specialty cap of 2.5. In a multi-specialty center, how many have just one OR or two ORs?
Well, there aren't any exempt multi-specialty centers, obviously, as you know, because the law hasn't passed yet. There are several CON centers in Georgia that I think have three. I want to say three, but they have certificates of need and they're not doctor-owned. But I think that if you talk about the 2.5 million, you know, you can't do more than two, depending on what you want to do in there. You know, a lot of them have one, depending on the specialty, it varies.
Thank you.
Victor Eden, one of the reasons, and this has come to my attention, the way that, to help the committee understand, they restrict competition, is that you have to, some of the things across the state is that you have to be a hospital-employed doctor to use certain facilities. Like if you are cardiology and you want to do heart caths, then some hospitals have said you have to be one of their physicians that's part of their program to use their heart cath lab. Is that
That's
one
true.
of the way they do it?
Yeah, one of the hospitals, again, varies in the community. They have exclusive contracts, what they call exclusive contracts, but basically they're employed physicians. They'll say to a cardiac cath group, we don't need your services because we already have our employed physicians, and you can't use our hospital because we're going to use our own guys. And sort of to segue back into something Representative Stevenson said, just to sort of follow up, is that when a doctor who's employed by again, not a hospitalist, but employed by a physician, employed by a hospital, has a choice of referring the surgery to an outpatient surgery center that's owned by our clients, or refer it back to the hospital, he's going to refer it back to the hospital for the same exact procedure. So again, that's one of the ways that I think you've got that impact on market. So.
Okay. Representative Stevenson? Yes. Uh-huh.
The idea with hospitals selecting specialty groups, that has been occurring prior to the acquisition of physician groups. Am I correct?
It's accelerated dramatically over the past, as you probably know, the past 5-10 years. In fact, over the past 3 years, it's just been it's like the gold rush in San Francisco. It's incredible.
But hospitals have had exclusive relationships with physicians, specialty groups for CAF prior to the acquisition of practices.
Yes. So what's happening instead of just having exclusive contracts with independent groups, they're now going to employed physicians and cutting out the independent groups. Correct.
Representative Reiners.
Thank you, Madam Chair. Several questions. Are you a lobbyist?
I am an attorney, sir.
Okay. Who do you represent?
I represent Independent Doctors of Georgia, but
thank you, Madam
I'm
Chair.
an attorney for them.
Mm-hmm. And if someone else was to, because you have an obligation to your family and everything, if somebody were to offer you twice what you make now, or 3 times or 4 times what you make now, and you decided to go to work for them, do you believe that was because they were trying to starve you out? Well, it'd be the same thing as if a hospital wanted to take those surgery centers and create their own competition. I would submit to you that one size never fits all, that perhaps the reason why they did it was because it was a better deal for them, better for their patients, better for their family, in some cases.
Yeah,
just like you would as an individual.
Yeah, if I'm a doctor and I get offered twice what I'm making, I might go be employed by a hospital. Absolutely.
Right. Okay. So some of those would be because it's just in the best interest of their situation and their family. And
from the doctor's perspective, yes.
Absolutely.
But from the hospital's perspective, they're trying to buy market share.
I'm going to follow up some more. Physician-owned, this came up in the pill mill. When we read physician-owned in the bill, does that mean that no one else can be part owner?
Well, the current law today says that 15% of single specialty centers can be owned by non-physicians. There's a 15%.
In the new bill, could I just be a 10% owner?
I mean, the law, we're not changing that at all.
Okay.
Address that.
Thank you. The 2 to 4% Medicaid, one of the hardest things that we do, and I've said this, I beat this drum for years, is we write law up here where one size fits all in Georgia, whether it's in the area of education, healthcare, transportation, and it really does change from community to community, rural versus urban. So with that said, on the 2 to 4% Medicaid, there's a part of my logic that thinks that why wouldn't we have a higher threshold of Medicaid if we're sitting next to Grady if you wanted to open one? Why not? Why wouldn't that be 10% there and maybe 1% somewhere else in a more affluent area? Why shouldn't anybody have to meet the requirements of that general geographic area?
But
is that illogical?
No, well, I think that's a good question, and I think that's a part of the bigger debate about how do we go about resolving these issues, because even assuming the Affordable Care Act goes forward as is, Georgia's not expanding its Medicaid program. You're going to have a slew of people that can't afford insurance that are not covered by Medicaid, and you've got to deal with those folks. But if you look at the CON law, really as it's been for years and years, nobody, hospitals, imaging, cancer treatments, there's a 3% commitment to get a CON. That's it, 3% across the board if you want a CON. And some of the older facilities, when they they don't need a CON, don't have any commitment at all for Medicaid or indigent. So I think that's part of a larger debate that we probably should have, actually.
Let's continue down that thought. If we have congressional balancing when it comes to transportation, if congressional district number 5 is 30% Medicaid, would you be open-minded to say then 30% of Medicaid should be done if anybody wanted to open up a single specialty surgery center in that particular congressional area?
Yeah, I don't know. I mean, honestly, I don't know. I'd have to think about that. That's a good question.
Okay. And finally, at least for right now, finally, on the 2 to 4% Medicaid, is it your opinion right now, as it currently stands, that everyone that we granted those exemptions to in 2008 or whenever it was, is it your understanding that right now everyone has met that threshold?
Well, in 2008, when the law was adopted, it only applied to the centers that were approved after 2008. So you've got a couple of hundred or 250 that were approved prior to 2008 that have no commitment.
But the ones that have since under that commitment, have all of them met that commitment?
You have to look. I would think so. There is an outstanding balance under the CON tracking report. Most of that money is CON centers, not exempt centers. So without going through every single one, I don't know the answer. I would expect they have. But.
Well, because you were making the argument that how they do this just because it's good for the community and things of this nature. So I would think that everybody's doing that. And the follow-up to that be if they don't do their percentage of Medicaid, what happens?
If you don't do the percentage for indigent, you're required to pay to the state indigent care trust fund. That money goes to the hospitals, not to the freestanding surgery centers or the doctors. You've got to pay a penalty.
Madam Chair, at the appropriate time, I'd like to know if anybody here knows if that trust fund has been met 100%, or if there's anybody that just. So, thank you for.
Sure. I think we have somebody here that can talk to you about that.
Thank you.
Okay. So, Representative Pack.
Thank you, Madam Chair. Two general kind of questions, and I tend to think of myself as a law and economics guy, and I really like that theory. One thing is, we have this system where we built, like it or not, we cut a deal. I'm concerned about the rural areas here. When you had a hospital down south where, like in Albany, where Representative Rinder, or Chairman Rinder lives, where they've invested hundreds of millions of dollars into facilities. In exchange, what they've done, we've given them a monopoly, pretty much, an effective monopoly. And while I see the argument that you have there, I'm a little concerned about the imbalance that we'll be granting. For example, we've made some promises. The state, as a policymaker, and whether or not it's good or bad, it's up to debate, that you could go ahead and rest assured invest and plant your flag there because there's a need there. Otherwise, that no significant amount of investment for healthcare purposes would be invested on there, and that's what we've done. Now, if we were to adopt the language that you've had, it's like a shock to the system, a cold shower. You know what I'm saying? I'm a little concerned about if, in fact, we're going to a more of a free market basis, like you said, whether or not it would, in fact, have a dramatic impact on those existing nonprofit hospitals in rural areas. I think metro will be a little better, but yeah, and so that's one concern. Are you willing to consider alternate language?
Yeah.
Okay.
Do you want me to address
No.
Okay.
It's at one point with the sponsor of the bill. That's something that I'd be glad to take a look at with him. Second thing is, explain to me one thing about to have an efficient market to drive costs down, right? You need consumers that are informed. The problem that I see is it's very hard for even people like lawyers like you and me, without substantial research, to determine where one doctor is better than the other. So I'm not quite yet convinced whether or not we're going to get the efficiency, because there's not enough information about quality of care, like we talked about. And secondly is if the consumer doesn't know and there are restrictions on what you could advertise because of federal rules and things like that, and we could complain all we want about the system that they design, but we also have to live with it. So how would you guarantee that the consumer would make an informed choice as to go to a facility owned by physicians versus a hospital to truly get the market to work and drive down costs?
I'm to respond. I guess responding to the second question first, the way it works today, you're right about information. I mean, I think it's important that patients, and over time, I think with electronic medical records and the internet, you're going to have more choices made by patients. Today, you're going to have, it's being done primarily by insurance companies saying, okay, who do I have in my community that I'm covered by? But remember, insurance companies negotiate with providers. So they go in and they negotiate to say, look, we're only going to pay you X dollars, but we'll send you all of our patients. So if I'm Aetna, for example, I'll say, look, I want you to sign up, but I can't pay you more than X dollars per procedure, but you'll get 5,000 people, so therefore you should be able to make money. But I can negotiate that rate. And the Aetna then says to me, but you know, Dr. Jones down the street, who has the same credentials you do, will do it for less. So you do have actually, there's definitely a market impact upon competition on the insurance side of it, because I've been involved in those situations where you're negotiating those exact things. And so you have those issues. I can tell you today that employers themselves, and I mean, where Phoebe is a good example, employers themselves are probably pretty frustrated because they're having to pay insurance costs and are greatly concerned about the cost that their local providers charge for procedures, because it's coming out of the employer's pocket, and they're having to pay their share of those premiums. And clearly that's an issue that goes into the debate, not just in Georgia, but across the country, where it's employer-sponsored insurance, because it increases their cost to keep their employees happy. And in some circumstances, they'll arrange for patients to go outside their community because it's cheaper. And that's the employer doing that. So the employer is very well aware of what it costs them to insure folks and what they're being charged by the local providers. And so I think that's that's my answer to the second question. In terms of the first question, I'm not sure if you wanted me to address that or not, but the rural issue is a very, very large concern for everybody. There are critical access hospitals in rural areas. And when I'm talking about rural areas, I'm not talking about Albany. I'm talking about when you're driving down I-16 and there's nothing there but a truck stop. I mean, you're talking about there might be a little hospital there that serves your ER. These surgery centers, for the most part, even the ones that are in existence today, are not in, quote, rural areas. They're located in population centers where they can be supported. In terms of having a dramatic impact or shaking up the system, you've got 250 to 275 in Georgia today that are single specialties. If you pass this bill, it's possible that some of those actually consolidate. So they're already out there. They're already providing those services. No hospital has shut down that I'm aware of because of a surgery center. And because it's limited by the terms of what you can build, $2.5 million, again, it's a little bit higher now because of the inflation number, and what you actually can do in a freestanding center, they're low-risk, outpatient procedures. Anything that's high risk needs to be done at the hospital anyway, even if it's outpatient. So I don't think there's going to be a dramatic impact upon really anybody.
Representative Pack, I will tell you that we have Phoebe Putney. It's our largest, most expensive area of the state for our employees' health care and our Medicaid population. So it is the one area of the state, and Phoebe is buying up all the little hospitals around, and we are paying an exorbitant amount state-wise in that area. And that's just nothing against the quality of the hospital or anything else. It's just the way it is.
While they rebuild tornado areas of Sumter County.
I'm not.
There's always two sides to every story. And I voted to allow another hospital to deliver babies, by the way. So I ain't got it.
Representative Reinders, I was not just
I understand.
telling how much.
That's my neck of the woods.
They were charging more before the tornado, okay?
There's other benefits, this would be the point.
Okay. Representative Beverly.
Excuse me. Thank you, Madam Chair. I have a quick question about competition, picking up on what BJ spoke about. If the capital expenditure is $2.5 million and the hospital invests how much to have the same sort of facility, probably in the neighborhood of exponentially higher. It's probably not $2.5 million. It's probably $10 million, $50 million, $100 million to create this facility where people can come in. So your cost to entry is actually lower to do the exact same procedure. So your facility fee would be lower, but your break-even point would probably happen at a quicker rate. Just because your capital expenditure is lower, you're probably going to have the same type of procedures going on, so your break-even is going to be lower, I would assume. Your break-even would happen quicker. Then how is that unfair, if you will? To create this opportunity, it seems like you guys are going to create a monopoly where you cannibalize what the hospitals do because your cost to entry is actually lower. And so in rural areas where your cost to entry is lower, hospitals invested all this money to get to build these facilities. You guys can actually cannibalize a hospital very quickly because of the break-even point. How do you mitigate against that in this particular bill?
Yeah. The issue of, remember, when a hospital builds an OR suite, they're built for both inpatient and outpatient for the most part. They're dual rooms, so they're not building the same thing that you can do in a little surgery center. They're spending a lot more money, a lot more complicated procedures are done in those ORs. They also do the smaller, lower cost ones and the simpler ones as well. There's no doubt, but it's an apple to oranges type of comparison. You cannot build for $2.5 million anything that can be built by a hospital and what they can do in a hospital OR. There's no doubt about it. You're limited to very low risk, type of procedures. Colonoscopy, for example, that you can do in an outpatient surgery center pretty easily. You don't need a full-blown $50 million OR suite to do that. So they're completely different type of things. In terms of cannibalization, again, because you're talking about one, we have to say that the predicate that that the hospital should have a monopoly is a good thing, which obviously we disagree with maybe. But if you say, okay, well, you're going to cannibalize some of this work, what you're going to take basically is the low risk, lower pay type procedures that can be done in an outpatient surgery center. That's being done today. You've got 250 to 275 single specialty centers who are doing it today. Again, I'm not aware of any hospital going out of business because of those. This bill just allows those actually to consolidate, because some folks want to actually join together and not lose their L&R, lose their right to provide outpatient surgery. The multi-specialty clinics that I represent, again, would be subject to the same cap. So again, it would be a lower cost, lower risk type of procedures being done in their ORs. All of the more complicated, higher cost, higher risk would still have to be done at the hospital. They would still be privileged at the hospital. So in terms of, is it going to take a little business? It might. I mean, it's possible. But I think at the end of the day, when you look at the numbers that are out there already and the idea that these folks actually, and one of the things that prompted this bill is that some of those single specialty centers have come to our clients saying, we can't survive in our little center by ourselves. We're a small group. We've got to join with a bigger group. So we either got to sell it to the hospital and they'll shut us down or make it part of their hospital-based ORs, or we can sell to you guys. We'd rather be with you guys. We want to be independent. So that OR would basically just go, that's already in existence today, would go to the multi-specialty group. So I guess we can look back, assuming this gets passed, and we can see the economics of it. Half the states in the country don't have CON at all, and everyone's doing pretty well. The hospitals are doing great. Some hospitals are not properly managed, may not do as well. But you have to keep in mind, too, in the current law today, what hospitals are doing, again, this is just the marketplace. It's not a blame game. Hospitals, and one in particular I'm aware of, is actually trying to buy practices 400 miles away from their facility. And the idea being, and I know this for a fact because I talked to the doctor that got approached, that they're being told that, look, yeah, we want to buy you, you'll be employed by us, but you have to send all your referrals back to the home base, back to the mothership in whatever city that is. So the hospitals are using CON, not just to protect what they do, but they're actually using it to basically stop competition and buy. And you've got a hospital in Vidalia that I'm aware of that is actually in Savannah, buying and affiliating with physicians in Savannah to send work back to Vidalia. They actually have an affiliation with a group in Dublin, right in the backyard of Fairview Park, another hospital there, and to send business to Vidalia. So, what's going on really is that they're saying, yeah, we need CON to protect what we do, but what they're doing is they're actually going out there and buying to try to take business and suck it back to their home base. So the question is, again, if I was them, I'd probably do the same thing. But the question is that good public policy? And should the state actually be picking a private entity for more benefits than another private entity? Remember, these are all private companies. And the question is, I don't think so. But again, this bill doesn't really address that bigger question. It really addresses just a little tiny bit. That's all that we're trying to do.
We have a couple more questions. Maybe like you off the hook. Representative Kidd.
Thank you, Madam Chairman. Just a couple of brief questions. But first, this is an issue that I'm very interested in. Going back to Clayton Brown, who chaired this committee years ago, and Sidney Marcus and Buddy Childers on the CON issues. The first place a patient goes, if I'm not feeling good or whatever, where's the first place a patient generally go? Do you go to a private practice office, or do they go to the hospital emergency room?
It depends on how bad it is. If he's in a lot of pain and thinks he's got a heart problem, he's going to an ER for sure. He's going to the hospital.
Is not the ER the most expensive place to get routine care?
It is, and what's interesting about the ER, I have to tell you, is that if you drive around Atlanta these days, you actually see billboards for ER saying you come to our ER, and you go, and there's actually ads on TV, which is surprising, saying because ER people, one of the big complaints is that we've got to treat everybody that comes to the ER. It makes us. They're actually advertising for folks to come to the ER because it's actually a tool for them to capture market share and get those good paying patients. So,
I agree. In that type of scenario, the patient goes to the private practice facility of the physician of their choice.
yes, sir.
And if it's an ambulatory surgery center that the physician has or would have under your bill, that would also be their private office, practice office, not just the AM surgery center.
Correct.
In most cases.
Right, they're next to each other generally. Yeah.
Right. From that standpoint. So, in all that scenario, wouldn't it be, well, let me go one question. If someone goes to the private practice office and needs surgery, and right now they refer that person back to the hospital where they're on the staff, hopefully on the staff, to perform the surgery. Under this bill, then they would basically be alleviating one stop going to the hospital first, and that'd be in the most expensive place.
Yes, sir.
Thank you.
Okay. Representative Sharper?
Thank you, Madam. I'm just looking at the big point of this, and this you may be able to get the answer to this. How many specialty clinics that are in operation now are on board to look at taking advantage of the multi-specialty surgery centers? How many do you know that say, look, if this thing is passed, we're on board and we're getting ready to start, doing
I
this?
just know my group has 3, Longstreet, Harbin, and South Coast, Savannah, Gainesville, and Rome. Those 3 I know would probably do one. So you got 3. That's what, I'm not aware of anybody else at this point.
Okay, because, it's just general, and you mentioned something about the procedures that should be done in a hospital versus the ones that are done in these clinics. And we have to look at a couple things, even though you may have the facilities, but sometimes it's going to be in the opinion of the doctor, because the same doctors that's doing the surgeries in the hospital but will be doing in these centers. And sometimes they say, well, we may not need all this equipment. We're going to still do it in our facility. And so that's just one concern that I have, that, there's going to be a lot of money made for these centers, for sure. And I'm just looking at the patient at this time, not just so much the money and the facilities. So we got to be aware that these doctors, they want the money, but what's going to happen to these patients when something does happen into one of these centers, and they're going to be shipped out in an ambulance or whatever. So I'm just wondering how many are actually waiting for this.
I can tell you that the 3 that I'm aware of, the ones I just mentioned, I don't know how many more want to do it. I mean, it's possible that some of the freestanding single specialties will come together to create a group because they don't want to be by themselves, but I don't know. I've not been approached, so I don't know if many want to do that. In terms of risk, I think that's right. I think doctors need to be mindful of that. And to get an LNR today, actually, even under today's rules, you've got to have a transfer agreement with a local hospital that if something does go wrong, you've got to ship them. But again, because of the risk and the liability, most of the things that are done in outpatient centers are really low risk. Procedures are not taking risk in those centers. Right.
Okay, thank you.
Okay. Representative Hatchett.
Thank you, Madam Chair. Just a couple follow-up questions. How many states don't have CON?
It's about half and half. I don't have the exact number, but it's about half and half.
Okay, so can you kind of comment on what has happened in those states that don't have CON as far as with the hospital relationships?
Yeah, it varies by state, but for the most part, Texas is a good example. Texas has 20 million people. It's a country into itself. So there's a ton of hospitals. There's a ton of surgery centers. Yes, there's been some increase in costs on some things, lower costs on other things. So it just varies by state. But for the most part, there's been no push to readopt those again. And I can tell you that in North Carolina, a bill got dropped recently. I think it was either yesterday or the day before, to address CON because of the restrictions. South Carolina, the governor there has expressed great concern about their CON program. Again, why do we have CON still these days? So I think you've got more and more push to question whether or not, even in states that have had it, which is surprisingly the southern states, whether or not you continue to need to have it in light of what free market would potentially bring to the patient community in terms of lower costs. Florida repealed a lot of it a few years ago. I'm not really that familiar, and I think that they still have it for hospitals. So it really varies, but for the most part, I mean, it's been a non-event, I think.
Okay. Victor, are you telling me that patients in Matt's district down in Dublin have now, because of, is it Vidalia?
Yes, ma'am.
And that's how I pronounce it too. Representative Reinders?
You actually pronounced it correct.
Oh.
I never heard of Vidalia.
Okay. I mean, I got it right.
Well, yeah, you did.
I got it right.
Well, I'm getting a rule argument.
So, are you telling me that they have to if they're sick and they go to the doctors there, they have to go to Vidalia to the hospital?
I would rather not comment on this.
Oh. Okay, that's what you said, Victor. How far is that?
It's a good probably hour drive.
So if I live in, live in where he lives, Dublin,
You don't have to.
where do you go? If your doctors work there?
Most of them work both places.
They work both places?
It's interesting.
Huh. Okay, so that they can work both places. Okay, and my question would be, Victor, okay, you said there's 240 centers out there that, before we change the law, somewhere like that, that are single specialty or CON. If the law changed, I mean, it seems like, and they don't do any indigent care, right? Because we only changed the law in 2008, and it was only the new centers. It seems like to me, should we do something differently, that one way to capture and have those that were before the law and the requirements would be to say that if they did merge, then they would have to pick up the indigent care requirement and pay the penalties.
Well, in fact, I think that the way the law is drafted is that I think because if they merge, they would have to get a new LNR basically, so it would require them to meet that requirement. Absolutely. So even today under the current law, I think that would be true.
That they would have to do that. Okay, Representative Reinders, last question.
Thank
for
you.
Victor.
Real quick, Representative Pack was talking about rural. I actually look at it more of a center of indigent population as opposed to whether it's necessarily rural or not, to that point. But also the access going to Vidalia or Dublin or other places. Are you familiar with Calhoun Hospital?
I heard this morning that it closed down.
Yes, sir. And do you know how long ago that was?
No, last year, I think.
Okay. Anyway, here's our problem in rural areas when we talk about the thing with Savannah. This is just for informational purposes for you. Do you think the people of Calhoun County or Arlington or Leary or any of those places, do you think that they would be better served in terms of access by just closing or by reaching an agreement with Columbus or Archibald and Thomasville or Valdosta or Phoebe and Albany? What do you think those people would want?
Yeah, I mean, I think that if I'm living in that community, do I want to keep my little hospital open? The answer is probably yes.
So if we've got a Baptist hospital in Sylvester that can't stay open, or if Mitchell County Hospital chooses to enter into an agreement with Archibald, would you believe that the access to those citizens would be an overriding compelling reason versus someone else who might just say it's someone else making a conglomerate bigger? You get the point. It's almost like a no-win. Some people would say the access is more important than whether I just made the network bigger.
Well, I understand that.
Do you think access is important in rural Georgia? Let's start there.
I think access is important everywhere.
And if they did that, if they kept it open to provide them that access, would you then accuse those same people of trying to build their monopoly?
I think that if you're asking me, does a hospital that we're talking about want to build a monopoly, I think my personal opinion is the answer is yes.
But if they're meeting the needs of the people who say, come give it to me.
I mean, I think that would be the same argument that let's go ahead and have a government-run program and have a government hospital, because let's have a single-payer system and a single hospital because it gets all the business and will provide services to everybody. I don't think that's what we want to do either.
But I got to believe you see the point. The point is if the people of the county sit there and go, I don't want my hospital closed, it got destroyed by a tornado, it couldn't make it as a county hospital, and someone else, I don't care who it is, comes in and says, we'll provide you that access, to me, that would be responding to the people. While the critics would say that's just the big getting bigger.
Well, I think
no win.
There's a balancing test you got to do. I think when they come in and they say we're going to save your little hospital, and all that business that was there, not much of it because the little hospital's in bad shape anyway, frankly. they're going to, all that business will go back to the mothership.
Right.
And that's part of the HIPS. And I can tell you that, there's hospitals out there that are going way outside their traditional service area.
And I don't doubt that. It's that balance that I'm just trying to get you to admit that there is a certain access is important.
Access is important.
Thank you.
Hey, Victor, that's the last question for you. I think since we have another CON, I'm going to let Representative Earl Earhart present his. Sorry, Earl. And then we'll take, back and forth, and just because I think they're both CON and they will have the same testimony back and forth. So thank you very much for coming. Thank you.
Thank you, Madam Chair.
Stick around for the rest of it.
Thank you, ma'am.
Okay, Representative Earhart, you have House Bill 404, LC 335053. Where'd he go? Right there. Is that the right?
Yes,
we got the right copy.
335053.
Wait a minute. Which one?
LC 335053.
Got it. That's it. Everybody got it?
Ready for me, Madam Chairman? Thank you very much, Madam Chairman, members of the committee. I think the conversation that we can have here, that was an excellent primer. I think the timing worked out well with the expert and the overall conversation with respect to CON itself. Disclosure, I am a co-signer on Representative Rogers' bill, so I have a 25-year history in this House of opposing the concept of CON. I've never found it to be something that the efficacy of at least the access and all the other issues you heard about, I don't find it beneficial for the citizens of the state of Georgia. But let's draw a distinction. What I'd like to do probably is draw a distinction in House Bill 404 that myself, Chairman Willard, Chairman Stevens, and former Chairman Harbin are bringing to you is a little bit different. I think what we can say is this really gets to the kernel of what CON is about, not in this big general sense, and I still think that's an excellent way to go about this, but this is very focused. I think it kind of smokes out what CON really is about. We're focusing it. This does one thing. Look at line 11. It allows freestanding facilities providing emergency services to pediatric patients only. Okay, so it's a lot more narrow than the previous legislation. This is about one thing. I want to try to demonstrate what we're actually involving ourselves in when we involve ourselves in the marketplace in creating monopolies, because that's what these are. I mean, you can put all the lipstick on the pig that you want here. I thought I'd try a rural expression for you there, Chairman Rogers.
You delivered it with make it a little thicker. You'd be perfect.
Okay, I'm working on that. But it is what it is. These are monopolies. These are franchises. A lot of businesses out there would probably like to have one of these franchises. That's a heck of a deal if you can get it. You got to go, if you're an attorney, if you're an ice cream guy or whatever else, if you could keep your competition down and every time somebody wanted to get in the market with you, then they'd have to go to the government and ask. Heck of a deal. And by the way, a lot of these folks, this goes back to 73, it goes back to the Hilberton Act, where we're building these publicly funded hospitals with public funds, and the bonds, those 25-year bonds have gone out a long time ago. These folks do pretty well. Not all, but so there's some interesting historical absurdities in the overall CON. Let me address something that was asked earlier too about what's happening in other states. I can tell you, I've been through Texas and some of the other states that have CON. Cats are not cohabitating with dogs. The sky is not falling. Healthcare is still being delivered. I want to make sure you probably hear some of that or something close to it when we hear some of the other testimony. And I'm not trying to make light of that in general sense, but some of the hyperbole that I've heard from some of my friends on this committee that has been expressed to you on the ropes, but some of these individuals who are protecting this ancient system is that absurd. And I think you could probably tell me some more stories about some of the things that these individuals had to say. But let's deal with what we're really talking about, and let's talk about the access to care. What this bill does is allow access to care for pediatric emergencies. Maybe you don't want to drive your child in rural Georgia or in other parts of Georgia an hour, 30 minutes even, to access an emergency care facility. Talk to the parent about that when it comes to be the practical reality, and then worry about whether or not you're protecting the candle maker rather than the person who came along with the electric light bulb. So just let's talk about what that is. And this is, the practical reality of this bill is we're not talking about independent physicians that are going to come in here and necessarily create a independent emergency center. I gave you a couple articles in here. We've had 3 of these freestanding emergencies turned down in this state just very recently. These are hospitals that want to do this. Ladies and gentlemen, you've heard all the again, the conversation with respect to this. This is probably going to be hospitals that want to do this themselves. But every time, we've got this, again, absurd system that every time even a hospital in the state of Georgia wants to do something to create access, to create a better market, to do some of the right things, they got to go through this system. They got to spend millions in attorney's fees. By the way, we probably could have funded that wonderful provider fee. The hospitals probably wouldn't have needed it if they just saved the money they're spending on attorneys every time they want to open up something new. They have to go in and say Mother May I to the government, and the only ones that are making any money on this are the attorneys who practice that kind of law. And that's hundreds of millions. So again, I'm trying to get to the kernel of what CON is by narrowing the focus here with respect to pediatric emergency. Let's allow these kids access to pediatric emergency. Let's allow some hospitals to do this. Look at the situation in Columbia County. That's the most recent turn down. That was 2 hospitals that wanted to provide that. It's a growing, expanding arena. And they turned it down because they said, in their wonderful wisdom, the people who make these decisions, that well, they can go somewhere else. Well, that's nice if it's not your child. If it's your child, you're going to want the closest, the best health care. Let's address this again, this canard about quality health care. I find that an insulting argument. I think that insults the physicians and the health care professionals in this state. They're licensed. They should be. You have to go, if Dr. Watson wants to go out and practice medicine somewhere and it doesn't have to do it under the auspices of a hospital, he can't practice that. He's just as capable inside the walls of a hospital as he is if he's in the walls of his office. How can you allow people to make that claim that there's a quality issue with respect to that? If physicians, I don't think these freestanding ERs are going to have leeches and medieval implements in them. I don't think anybody'd show up at their doors, and I don't think the state regulators who regulate healthcare would allow that. Let's please let's deal with the facts in this. If a doctor who's practicing in a hospital can practice just as well down the street. We don't have to support some of this failing system. The cost, again, you heard the testimony with respect to the cost here. It is demonstrably lower in these. I mean, the market very clearly will benefit from lower cost on these facility fees and that kind of thing. That's a no-brainer, ladies and gentlemen. So we need to, the gall of some of those who disagree there. Let's don't drive up healthcare costs. Let's drive them down. Why do we need this? We've had 3 standalone ERs rejected in the last 3 months, at Columbia County being one. This is what I'm trying to do is a measured step that will start us down the road towards solving this problem. That's really what I want to do. And somebody was going to say, do doctors benefit from this? No, this bill is not about benefiting doctors or benefiting these hospitals. This is about allowing healthcare providers to provide care where they're willing to do it and where the need exists without unnecessary, and this is critical, interference from the state. Monopolies always, and Representative Pack, I appreciated your question. I also consider law and economics a crucial metric when you're discussing these. But the laws of economics are clear with respect to monopolies. The cost, although sometimes originally they're lower, they always go up. It's a curve that's you can demonstrate algebraically or however you want, but it is it is the invisible hand. It is as inevitable as a monopoly is in those cases. So, and what Chairman Cooper said about that is relevant as well. So, I ask you, I said, let's begin this conversation with allowing health care for Georgia's children to emergency services. And just finally, I want to address sometimes the ooze from the hallway gets a little old, even after 25 years. Some of you have related to me particularly, and this is not directed at 99% of the people behind me, but somebody. I always like to stand up and say what I'm thinking, and there's this fascinating little story that's being told that I'm doing this to benefit a project of mine. I'm building a big project. And one of the associations that I have is with a provider of children's care. Well, the idea that is some type of conflict of interest, when effectively that same provider is going to disagree with me on this, and effectively I'm kicking my own client in the teeth. I haven't made a success of businesses by doing that, but this is important to me. But I just wanted to face that with you. So if take that as a and I know who's saying it, and I hope that the 99% of the people behind me who are professionals and do this every day will ostracize these individuals. But they'll, generally those kind of lies don't work out. But I wanted to let you know that because I know you've heard that, and so you can see on its face how ridiculous that is. But thank you, Madam Chairman. I'm certainly willing to answer any questions.
Well, I have a question, and maybe it's a statement. So far, there hasn't been much discussion about the patients, and I will have to admit I've been in the OR a lot at Wellstar lately with my husband because he's ill, and I've gotten great care at Wellstar.
Great hospital.
However, having taught pediatrics, if I had children, I would prefer that they not have to see everything that I saw and wait and go on. If there was an alternative to one geared toward children. I mean, we just haven't had much discussion that way, but the emergency room is a pretty scary place, and and the hospitals do have very busy ERs, and since it's hospitals asking for this exemption, if that was ever possible for hospitals to run a separate thing geared toward children, I would certainly think I would be in favor of it so that they were not taken to the OR with everyone that is drunk, been in an accident, having a coronary, hysterical, blood everywhere, throwing up in the halls, and this kind of thing, that they would not be subjected to that, but that's my personal opinion, and I expect hospitals would be the best people to run that kind of an ER, not private physicians. But I hope there's some doctors going to testify about the patient's advantage to this, and we talk more about the patients. Okay, questions? Representative Kidd.
Thank you, Madam Chairman. Mr. Leader, who's going to staff, who's going to staff these pediatric emergency pediatricians?
Generally, my understanding is that there's a specialty in pediatric emergency medicine that is distinct from the regularly practicing pediatrician. Yes.
Because obviously you'll have the nurses and all that kind of stuff, but you'll have the if that is a specialty in and of itself, which I think it is, would they really need a CON if it's a single specialty pediatric?
Well, in the case of those that have been turned down, the best legal opinion I've got that if nothing else, Representative Kidd, those that wouldn't want them to do it would still file the suit. They'd still have to walk through at least the beginnings of the CON process, and they'd probably, at least with the predisposition between the group that decides on CON, they'd probably agree that they needed to have a CON for this.
Well, I would agree, because I've been fighting hospitals on this for 30 years. Thank you.
Representative Rogers.
Chairman Earhart, I wanted to ask you, you and I have talked about your project, but very interesting what all you're doing. I want to disagree on a monopoly, though. I think I'd rather be a utility than a hospital. Don't you agree with that?
Degrees of monopoly are nice if you're the one that's got the monopoly.
Okay. Has anybody from the area that opposed this bill that you mentioned, have they visited with you to talk with you on this matter?
Very few, but a couple of the very professional groups have, and I appreciate their input, and I respect their opinion greatly.
Okay. Going back to I understand your concern on the standalone. Managed care contracts. I know you have an opinion on that too. Can you?
Very much like yours on that. That's something we need a long conversation on, and these managed care contracts are part of what's driving the overall healthcare cost across this nation. And
yeah.
I don't have the panacea for that.
Okay.
I would defer to the wisdom of this committee. This is the first time I've been in your committee in 25 years. It's such a pleasure to be here. So I see the amount of work and the difficulty of these issues. I have a new perspective. But
so you really feel that the CON laws shouldn't be there?
Yes, sir. I think that, again, the experience in other states, the world has not come to an end. The access, I think, is demonstrably greater, and I think the market is working very well there.
Okay. Thank you.
Representative Morgan.
Thank you, Madam Chair. To my friend from Cobb. So I have some life experience with this. I have 2 kids, and both I've had to take to the emergency room, or at least both have had to go to the emergency room by ambulance to get to the hospital, only to find out that they need to go somewhere else. And so I can understand this. But my question is, do you have a sense of the level of interest and what this would look like? So are there more pediatric doctors, outside of the metro area that have an interest here? Is this a rural issue? Help me understand where this interest comes from and where we might see these kinds of facilities around the state.
Certainly, Representative Morgan, I appreciate that too. I think you and I probably have a standing reservation at the same ER there at Wellstar with our children. I've been there, and I would like to say they have one of the most child-friendly, because they've segregated the children's section there and done an unbelievable job with that. That's important for the patient.
Is that out in Cobb?
That's out in at Cobb, what used to be Cobb General, the old.
Not the big hospital, but Cobb. Oh, good. Thank you all for doing that.
They do a great job there.
I go to the
like I was saying earlier, I don't hear necessarily a clamor for these. My personal opinion is I think this will help the access more in rural areas. I think Columbia is a good example of that. Although even in an area where we're well served, we don't have to go very far to get to Wellstar's emergency care. Maybe there would be an opportunity in certain even outlying areas of there that these same hospitals could see a need, just like they see for other ancillary centers that they set up, that they can provide even closer access for pediatric emergency care in that sense. So I think, again, what I was trying to say is I want to get to the kernel of what CON is really all about. And I think this pediatric access, this pediatric care demonstrates what I consider some of the absurdities of hanging on to this vestige.
Gotcha. Madam Chair, I think it's important for me to end my comment by saying that I have received great care at Cobb Wellstar. My mama works there too, so I need to make sure I say that. As well as Children's Healthcare of Atlanta. Name. I will not say her name. Okay. But I do want to say that publicly, that I appreciate the services that we've received every time for our entire family, and I'm grateful for that. So I wanted y'all to know that. And know that I'm on record in appreciating great quality service at both of those places.
Well, I have the same experience. It's just that we go to the main hospital from East Cobb, and it doesn't segregate the children because it's the old ER, and it may be busier. So, but we get good care when we do have to go. But I will say that Children's Hospital, just so the committee will know, and Wellstar have both recently applied for a CON on imaging, for special imaging centers for pediatrics, and I wrote a letter for both and said I believed in competition, and both were given the CONs to have that because there's so much growth and so much, people are moving into the northern area of Cobb, and the lower part of Bartow County. And there's so many children that they were both granted a CON to have these sort of specialty areas with children. So a little bit of
Sometimes it works.
Sometimes we're talking a little bit of what we're talking about here. Okay, Representative Henson.
Thank you. Who is requesting this bill?
I am.
Okay.
Myself, Chairman Willard, Chairman
Well, I know,
Stevens.
I understand that. I know who's on the bill, but what precipitated this, especially for pediatric?
My philosophical conviction that CON, and especially in the case of child patients, is wrong. That precipitated it.
Have you brought this bill before us? Oh, no, you haven't. You haven't.
No, this
been
is the
before
first time I
committee.
brought this bill this year.
But your children are older now, and I could understand you bringing this in the past 25 years that you've been here. Why are you bringing it now?
Because now we're having a conversation. I think what precipitated my personal interest in this year was the insistence on the provider fee, and then the juxtaposition of that, and then saying, well, and by the way, make sure you get us all these hundreds of millions of dollars, but don't even consider CON. I thought, you know what? It's time to consider it.
When you say the insistence on provider fees, I'm sorry, somewhere I'm missing something.
You know, we just pay the euphemistically called bed tax.
Yeah.
That and the juxtaposition of that, and a certain insistence by the same group that, by the way, don't even think about CON in a juxtaposition with this. That bothered me. I found that to be galling.
I'm sorry, I guess when I think of provider fees, I'm really thinking about the reimbursement rates that are being given to medical and dental providers. So I think we sometimes look at things a little differently when we hear certain words. Thank you.
Thank you.
Okay, Representative Sharper.
Thank you, Madam. You mentioned earlier, I may have heard wrong, but you mentioned that the hospitals are interested in you basically presenting this?
No, sir. I haven't heard from any hospital with respect to presenting this. I think the hospitals would be the ones that would actually benefit from this, because it's just not a practical reality, at least in my mind. For it could happen, but it's more than likely that it will be the hospitals themselves, because if you look at some of the materials I gave you, you can see that there was hospitals in the Columbia area who were looking for more freestanding emergency care. So my opinion, and that's Mr. Representative Sharp, that's all it is that hospitals will be the ones that could provide freestanding pediatric emergency care.
Okay, okay, that's what I heard about. They would benefit. My thing is, when we look at the freestanding facilities from a hospital standpoint, a lot of times most kids, economically, most kids are in school when it comes down to a lot of the emergencies in the daytime, and I'm seeing more hospitals create little areas inside their facilities just for, you know, the emergency, the pediatric kids. But when I look at the freestanding, there again, if a child or a parent understand that the child has a pediatric emergency, a lot of times they're going to go to the emergency rooms anyway. But if they go to a freestanding facility, more than likely they're going to be transferred to a hospital. So, you know, I don't know about the benefit that much for.
Let me respond to that this way. There's a 65% increase in freestanding ERs since 2005.
For pediatric patients only?
For all across.
Okay.
All across. I mean, to me, that demonstrates a need in freestanding emergency care. Well, again, what I'm trying to do with this is to demonstrate, to me, maybe that's just a personal predisposition, but to me, the most important emergency care is that when your child needs that emergency care. So I'm demonstrating what I consider the importance by saying only pediatric care. This could as easily read all freestanding emergency care. But again, what I'm trying to get across in this conversation that I want us to develop is that pediatric emergency care makes a good example in my opinion. But what I'd say is, unlike an urgent care center that are out there now, freestanding ERs are generally open 24/7 in other states. That's the experience. So they have the same hours, the same access as hospital ERs. That's the experience in states that don't have the CON process or that allow freestanding ERs on a regular basis. Some of these 65% that have grown since 2005.
Okay, Representative Reinders.
Thank you, Madam Chair. To my sweet mate, I've always had an immense amount of respect for your bulldogged persistence, passion. I'm trying to develop that trait myself.
Yeah, but just stick with
That was your friend, Chairman Rogers.
It's not your first rodeo, not mine.
That's correct, sir.
You and I know that when we get on the ropes, forget this issue, many other issues, if we don't do this immediately, whatever this is, children are going to die, the elderly is going to starve, everybody paints us the worst case scenario. Carl keeps moving and we keep missing eye contact.
Okay.
We get that every single day on a variety of issues.
Yes,
fear-mongering at its worst. We see it in Washington, down here, and I'm a regular guy. Me and you talk about this all the time. Do I believe that we've got entities that use things for the purposes of locking out competition? Absolutely. There's no question in my mind. Do I believe on the other side that there's people, in this case it would be the physicians, that want to medically cherry pick? Absolutely. And all I'm trying to do, it changes from place to place. It does. There's no doubt in my mind. All I'm trying to do is for regular folks like us that are sitting up here that are not experts, that aren't married to physicians, that aren't on hospital boards, that are just trying to figure out how do you find that balance where we're sitting here talking about someone's market share, and you know that. You're right. If this thing passes and CON blew up tomorrow, the end of the world, it's not World War III, but just help us regular, everyday legislators figure out how do we find that balance if that's what we're looking for, because both people are talking market share.
Representative Rogers, I appreciate that sentiment, and you and I have had a lot of conversations about that. I guess what I'm saying is let's find a way to continue to test this boundary. We're dealing with boundaries that were created in 1973 and earlier. Let's test it incrementally. Let's continue this conversation. There's not a one-size-fits-all. I'm in certain agreement with that, and like the chairman said, we can't. I just don't think the current system is working the way it ought to, and this is a beginning, and that's what I was trying to accomplish.
Representing Reinders and for the committee and the new members, since I am a nurse and I am married to a physician, and I chaired the CON committee for 2 years and served with Pam on that.
Those stories are legendary.
Yeah, well, don't believe everything you hear.
I don't. That's why I ask you.
Okay. But I will say, yes, doctors who start freestanding clinics do expect to make a living, but often that's not only part of what motivates them. According to what the testimony was before, and probably some of these doctors will tell you, my godchildren's father is an ophthalmologist. Used to, when they had to use the hospital, because taking out cataracts takes at the most about 15 minutes, and they had to use an OR, and then it would take 45 minutes to an hour to clean that OR to get another case in it. That's very time-consuming for a hospital for a very brief procedure. So he would get put to 4 o'clock in the afternoon, 5 o'clock in the afternoon, and most of the people who need cataracts are elderly, and they have elderly spouses, and so they, would not like having to take that person home on an outpatient basis at night and drive at night and so forth. When he was in the hospital, because they dealt with all the different ophthalmologists, every different doctor wanted a different instrument. You would have a tray of instruments to do a cataract that cost $300, and he would use 3 instruments. Where now in his center, and one of the ways they can save money is they only have the instrument that he's going to use. So,
but that doesn't end the medical cherry picking on one end and the monopoly on the other, which was my point.
No,
that's a great story.
Well, I'm trying to say it's not the only reason. For low incident situations, right, there's less chance of infection. I mean, not that it's the hospital's part, but hospitals treat all sorts of kinds of patients.
Right.
And you often run a greater risk of having, in fact, I'm waiting on my total knee replacement till they can do them in an outpatient facility, whether it's hospital-owned or doctor-owned. I don't want to go in the hospital for a total knee. But anyway, so there are other reasons that they own these centers, convenience, patient, being quicker for patients and so forth, than just the money factor.
I wasn't even trying to bring up the money. I was just trying to bring up the case of most people paint worst-case scenarios, and if we don't say that, we can't have an honest dialogue. That's my point.
Okay, well, that's why I thought I'd put up the other side.
Thank you.
Representative Stevenson.
Thank you, Madam Chair. And Mr. Chair, to you. First of all, I am a member of a hospital board, but I also have a long history of advocating for health care regardless of regulations.
That's right.
I've represented and advocated for just as many positions because hospitals can't survive without physicians and physicians cannot survive without hospitals. So with that said, in your vision, Mr. Chair, regarding the delivery of freestanding emergency centers, what is the relationship between the centers and hospitals? I know you said earlier that there's an expectation that some may be owned by hospitals and then others may be privately owned. But are you envisioning that the centers will also have to meet EMTALA laws, and will there be some type of affiliation with the hospital for inpatient care if needed? Because it's one sentence, but how is it related to the whole spectrum of if you need surgery, if you need to go to a hospital?
Okay, thank you for your question.
You're welcome.
Certainly I don't have a crystal ball with respect to all of the
Right.
options. I can only draw on the experience in other areas that allow more freestanding emergency rooms. Again, this is not necessarily a new concept. It has been significantly successful in other states and in other areas. What I would say is that it's merely, again, as related to Representative Sharper, is my opinion that because of the practical realities of a situation with respect to emergency care, hospitals are those who generally participate most in that. And I guess, again, I want to take it back to what I'm talking about. To me, I find it unseemly that the hospitals have to compete against each other. It is almost pro forma now when your hospital or another hospital wants to do something else. It's a basic business practice to go in and go against their request for a CON because it just helps you in a business metric, and we have supported that system. I can't imagine. Well, I can imagine. I know what some of these costs are. We've created a system that creates that kind of system, and that's self-defeating in my mind. Again, what I'm trying to get to with this is a demonstration of some of the problems with the overall system. Again, philosophically, I have one perspective, but this particular legislation, I am very confident that if this were to pass, that many of the hospitals in Georgia would probably take advantage of this. They would probably open up these types of centers, and I think we would find that they would be very successful. And they would, as in other states, be subject to all the same EMTALA regulations that any other emergency care facility would be. Because my understanding of the federal statutes is they're care specific in that sense, not facility specific.
Then my question is, because this is an exemption, and notwithstanding any of our discussion on regulations, who's going to outline? Will this just be you bill and then you license? I'm trying to understand the logistics behind it. If it's totally exempt.
Just as if in the example in Columbia County where they wanted to do this,
was theirs pediatric?
No, that was
okay.
full.
This was full service. Okay.
Full service.
Okay.
Freestanding emergency room. They already, those individual hospitals already went through all of those metrics.
Mm-hmm.
They have to. I mean, they're regulated just like every industry in the state, and I would submit over-regulated. But they have to submit everything from a land disturbance permit to get started on the building, to all of the necessary medical licenses, to the emergency care licensing that the state requires in a lot of areas, and that type of thing. To the Department of Community Health has. Believe me, there's enough folks over there that they got days and days of paper. They'll be glad to have you come in and fill out before you can do anything, even you at your hospital or anybody else wants to do. So those issues have been worked out, in my mind, Representative Stevenson.
Thank you.
Representative Howard.
Thank you, Madam Chair. I appreciate Representative Stevens saying what she just said about you know, hospitals can't function without physicians, and physicians can't function without hospitals. I mean, that's a hand-in-hand partnership that's always been there. And I've listened to, you know, the debate on both sides on your bill as well as the one prior to you, and I'm trying to get my arms around understanding. You know, we have the situation across the state with trauma care where we do not have, you know, real true access to care for emergency rooms. When you get into, you know, South Georgia and in some of the other metro areas like Atlanta and maybe in Augusta and Columbia County, you know, we do have access to care in a better way. You know, obviously there's always room for improvement. And I guess I would assume that that's what you're attempting to do here.
Yes, sir.
But my concern is going back to the elephant in the room, or whatever that cliche is, the CON piece. You know, we've committed our hospitals and med centers to have that certification. And we want to exempt these facilities. Is it fair to the hospitals to is the playing field level when you do this? And I'm concerned about, you know, keeping a balance, because I don't want to see us put pressure or put undue pressure may not be the word, undue pulling resources from hospitals that are functioning, you know, strong in neighborhoods and in communities. We have a pretty large medical community in that Richmond or Columbia County area. And I guess my question would be, yes, it would be great if that's what that community wants. Columbia County for freestanding, but what does that do to the whole medical community when you are going to pull resources? And is there a need for more access to care? Because I'm not hearing these horror stories about they couldn't get to the emergency room. Maybe you know more stats than I do, and I live there, but I haven't heard that in our area. But when I hear about the trauma units that we don't have in South Georgia, where you can't get to a level 1, level 2 trauma center, then I think, you know, I would rather see us focus in on those areas than getting into this competitive thing with hospitals and doctors, where they actually are partners in this whole process. And I guess that's the part I'm trying to get my arm around to understand where you know, why is this such a big deal?
Okay. Long question. Now, let me see if I can address your points, Representative Howard. The first thing is, I guess with respect to hospitals, they weren't, you know, I get a little bit of a kick out of some of the concept that these are, you know, these very sensitive entities that are going to be devastated by a little bit more competition. These are sophisticated business operations that can handle a little bit of competition. Again, I'm going to move back to the experience in other states. The sky has not fallen when hospitals were forced to compete in freestanding emergency centers. Actually, the access to health care has expanded for those children, for those individuals. I would suggest that if there wasn't a need, there wouldn't be a demand for freestanding emergency centers growing at a rate of 65% across this country since 2005. So I would suggest that we let the market handle that side of the equation. You know, some of these hospitals were built with government bonds. They're being given a monopoly through the CON. And I mean, I can't develop a lot of significant sympathy for a modicum of competition in delivery of services if it benefits the children of the state of Georgia, or the health care of all citizens who have a need for access to emergency care or any of the multi-specialty cares at a reasonable price when health care costs are going up. So I guess in a general sense and in a specific sense, the need for this access is there. I think it's, at least in my opinion, it's been demonstrated, and I would hope that we could continue this conversation to open up the doors to more access and more competition in healthcare, because I think.
So I guess what would help me is to hear from the hospitals, so that I can kind of get a good
I suspect,
balance.
Representative Howard, they're going to have a lot to say,
Yeah, right.
and they may or may not. I would suspect they're not going to be wanting. Listen, if I had, if somebody built my business completely with almost 100% government funds, and I had a monopoly, and somebody wanted to make me compete, I might be sitting on the other side of this table, saying, "Please, don't open up." I kind of like my deal. But since I'm not, that's why I think our job as legislators is to look at the best interest of all the citizens and all the care.
Yeah, and I think we all will do that.
Yes, sir.
Right.
Representative Pack.
Thank you, Madam Chair. Mr. Chair, I noticed that the exemption is going to go into number 27th, exception to the exemption. That kind of triggers that. It's about time to look at the rule if we're going to have 27 exemptions. Secondly, it comes down to a simple question for you and also, I guess, the hospitals on this. I think you mentioned some of it. After 25 years having the CON, we've given them monopoly, we've given them tremendous amount of tax breaks, and matter of fact, I think we voted on another one on Ways and Means on this. Have the cost of health care have ever gone down? And related to that question is, and I think
No.
you answered it from has the access and the quality of care gotten better? I mean, those are the two general kind of questions. Do you know, you mentioned that in other states you said the access to the children in the emergency context have improved. Do you have any, because I tried to do some research on this when the bills got on the committee. I couldn't find any data, and it's hard to kind of compare apples to apples because of all the incentives that we give the nonprofits and things like that. Do you have anything that you've seen?
Yes, I mean I've got several files. I'm more than happy to show, and I don't think there's been an exhaustive or definitive study with respect to the because again it's fairly new with respect to some of these opening up of the access. This has been the way, again, as he testified earlier, this was in response to a federal requirement in 1973. So things are just now starting to open up. I mean, there's anecdotal evidence. There are some studies, and you and I can sit down. I'll be glad to show you some. You may even hear some testimony with respect to that. To answer your specific question, I don't think, other than in rare instances, the cost of health care is going down. Unfortunately, all of us have experienced the cost of health care going up. Has the quality of health care been better? Yeah, I'd submit yes. In many ways, the hospitals in the state of Georgia are at the leading edge of providing quality health care. This is not from Earl Earhart bashing the hospitals. I hope that has not in any way come across. What I'm saying is there's always a way that we as legislators can get out of the way and let those who are capable do a better job without us having to be always in the mix as because we generally don't do a good job. We as in the government entities.
Is the quality of care better because of their ability to invest money that they get, granted through the monopoly?
I suspect they would say yes, but I would suggest that if we allow innovation, and I mean his history has proven that many of the greatest discoveries, the greatest leaps in technology are by the individual tinkering with something in a smaller area all by themselves. Some of the greatest research. I think what we're doing is by having a CON is saying the only way you can do this is this. Why not open it up and let some of the free market work and some of the freedoms that some of these individual in the previous bill surgery centers might be able to innovate.
Thank you.
Representative Earhart, that is the last of the questions for you. Thank you very much. I've been asked by a couple members of the committee for us to take a 10-minute break. They said 5, but I know you won't be back in 5 minutes, so 10 minutes to get a Coke, go to the restroom, whatever.
Can I ask a quick
Sure.
question? Thank you, Representative Chairman Cooper. I did want to ask, and certainly at your pleasure, when I started, I said I really want to make this a conversation. I'm not looking to place any of the members of this committee in a situation between myself and their local hospitals or anything like that. So I'm not asking you to necessarily vote on this today. If you want to, that's fine too. But I'd like to continue to get us to a point. I want to get past the hyperbole and this rope nonsense at times, and I want to seriously begin talking to the individual members of this committee about how to solve this and move forward. So I defer to your wisdom, but I wanted to let you know that I'm good either way.
All right. Thank you for that. I'll take that into consideration, and after we hear from the other people that want to testify, then I'll make my decision about whether we want to vote on either issue, one issue or not.
And I do have to get back to my business, so
Thank you very much.
I'm not being disrespectful.
No, please. Go ahead and go. Thank you very much. All right, 10-minute break, please. Will everybody get back so we can have a quorum? Temple, let's get started. Temple, are you representing and going to present the hospital's response? And
well, I think there's some other folks on the hospital side, but I'm certainly on the hospital side, so part of the response, I guess.
Okay, tell people who you're with for the committee members that don't know. And you,
certainly.
I also know Temple like I know Victor, so please forgive me calling him by the first name, but after 2 years of working on CON,
I'm going to have to go like this. Madam Chair, thank you. Members of the committee, I am Temple Sellers, and I represent the Georgia Hospital Association. For those of you who may not know, GHA is the largest trade association in the state that represents hospitals. All of the acute care hospitals are members of our association. So we have the for-profits, not-for-profits, urban, rural, all are members of our association. And I appreciate the opportunity to talk with you today about the hospital community's perspective on health planning in the state of Georgia. I'll talk not nearly, I think, as long, hopefully,
Please.
and the questions hopefully will also not be as long, about both House Bill 279 and then a little bit about House Bill 404. I think there are some different, to some degree, public policy issues related to those bills. But what I'd really like to do is just explain the hospital community's perspective, because I think the role that hospitals play in the delivery system really informs our perspective on certificate of need. And, as Victor said, some of this just is about the different roles and different functions that hospitals play versus ambulatory surgery centers. First, let me just say that for those of you who weren't involved in the multiple-year debate related to certificate of need, that certificate of need is the health planning program in Georgia. And in essence, there are two things that you're trying to get if you're trying to get an exemption from certificate of need from health planning. One is an exemption from demonstrating that there's an unmet need for the service in the area that you want to provide it. And the other is that they're showing that there's not an adverse impact on existing providers. So it's about unmet need. Is there an unmet need in the planning area? Is my project going to have an adverse impact on existing providers? And, the question of whether it's in the public interest to ask these questions to begin with really does depend on where you sit in the healthcare delivery system. From the perspective of the multi-specialty groups who are providing surgical services, outpatient surgical services, they're looking at this, and I think you could hear from the testimony that they're focusing entirely on those services, and that makes sense. That's what they do. They provide outpatient surgical services, as opposed to hospitals that they do certainly provide outpatient services, but hospitals exist to meet a full range of healthcare needs of their communities. So there are a lot of services that hospitals provide, and this is the key. There's a connection in the minds of hospitals between a lot of the other services they provide and services like outpatient surgery. For example, there's a connection between the ability to provide trauma services and emergency services and intensive care services and the ability to have some profitable services to help pay for them, because those services just don't pay for themselves. You know, healthcare, it just is so different than any other part of the economy, and we talk a lot about free market, but the reality is government is the #1 payer of healthcare services in this country. I mean, we know that, and nobody negotiates with Medicaid about what they're going to be paid. You don't negotiate with Medicare about what you're going to be paid. You're paid what the government decides to pay you, and the reality is the government oftentimes pays less than cost. And so, you know, the ability of hospitals to meet the full range of needs of their communities depends on the ability to provide some profitable services to be able to pay for these other services. So when we talk about, does it make sense to say, is there an unmet need in the community, and is there going to be an adverse impact on existing providers, from the hospital community's perspective, that question makes a whole lot of sense, because the only way we're going to continue to be able to meet the full range of services is if we have some profit centers. These debates about certificate of need, actually, maybe with the exception of House Bill 404, which I'll talk about in a minute, the exemptions that people want to get are always for just certain services. You know, we're not debating, you know, the hospital shouldn't have a monopoly on trauma services or intensive care services or emergency services, because nobody else wants to provide those. I mean, it's just not, it's not even appropriate for that care to be provided oftentimes outside of a hospital, because they're open 24 hours a day, and you know, it's just a completely different role. And market share, you know, hospitals have 100%, I guess, of the market share for trauma services and for you know, intensive care units and things like that, and they just don't pay for themselves. So it's important for us, from a public policy perspective, that lawmakers make a connection between those things, because they're essential for our business model, and it's essential for our ability to meet the needs of all the patients in the community, not just those that need outpatient surgery. Victor said something that was, I think I really want to reiterate, which is that these centers serve the least acute patients that need outpatient services. And that's, I mean, there's nothing, I'm not maligning these centers, that those are the patients they treat. That's probably medically appropriate. Hospitals, on the other hand, in their surgery centers, treat the most medically complex patients, and these are the most expensive to treat. That's the problem. I mean, people, you get paid the same thing whether you're treating somebody that has multiple medical conditions, and you're providing them a surgical service, or somebody that's really in very good health. But the amount that it costs you to care for that patient differs tremendously. So these patients that a multi-specialty ambulatory surgery center would treat are the very patients where hospitals are able to make some profits that subsidize these other services. If these centers are allowed to open up without going through the health planning process, and by the way, I just want to make sure everybody understands that hospitals can't open multi-specialty surgery centers without going through the health planning process. They have to go through the health planning process if they want to do that. So I'm not sure there's, you know, quite the same issue regarding level playing field. I mean, everybody has to go through that process except for these small groups that have they're single specialties, and they tend to be really small groups. There usually are not a whole bunch of physicians in those groups. Opening up the ability for multi-specialty ambulatory surgery centers in areas where, if there's no need, that means somebody else is providing the service, and most likely it's going to be, these patients are right now being treated in the hospital. But when you open it up and allow large groups, because these are very big groups, all of a sudden those physicians now have a financial incentive. And there's nothing wrong with financial incentives, but the reality is you have a financial incentive then to refer the patients to the surgery center that you own instead of to the hospital. And that is where you get the problem. If if this was a free market, if everybody was providing the same types of services, if hospitals weren't providing a whole bunch of services that don't pay for themselves, we'd be having a different conversation. But that's just not the reality. And I want to talk about a couple of things really briefly. One relates to this indigent charity care issue. You know, I've been thinking about this actually over the last couple of days because as the hearing got rescheduled, and, you know, I have to be careful with this because, you know, our members, hospitals in this state were very supportive and continue to be of making sure anybody who opens a healthcare facility in the state should treat indigent patients, should do Medicaid. But the reality is the problem with these multi-specialty ambulatory surgery centers, I don't care how much Medicaid and indigent care you require them to treat, it's not going to address the underlying problem that exists for hospitals if these multi-specialty surgery centers are allowed to open next door to the hospital without showing there's any need and without a consideration of adverse impact. And it's because, you know, most of the uninsured and indigent patients that hospitals treat, it's through the emergency departments. I mean, people come to the EDs. Not all. I mean, certainly there are you know, plenty of Medicaid patients that are treated and uninsured in other respects, but the vast majority of the cost are associated with emergency services, and those patients just aren't going to show up at ambulatory surgery centers. I mean, they're going to still come to the hospital. The hospital's still going to have the exact same amount of costs associated with, you know, providing those services, the fixed costs. So, you know, that's just the reality. And the services that these multi-specialty centers are offering, those services they're elective services. And the reality is most uninsured patients don't get those services. Some do, but I mean, yes, everybody needs to meet indigent charity care requirements, but the reality is the problem that this creates for hospitals is the patients that these centers are going to serve are the patients that are making the money right now for the hospitals to subsidize these other services that everybody needs. That's the reality. It's about who they're going to treat, not who they don't treat. And we simply can't address that legislatively. So I just want to make sure that point is clear. Finally, I just want to mention that, you know, we have had these same arguments, these exact same arguments that you heard today were heard over 2.5 years, actually. For those of you who are new, in 2005, the General Assembly and then Governor Perdue created a commission on the efficacy of the CON program, and there were 11 members appointed. And, you know, all of these issues were discussed. There were meetings over a year and a half, numerous hours long, got into details, data, everything. And ultimately, when the commission issued its report and they looked at, you know, is CON, does it meet a legitimate need in this state? If so, what is it? Do we need to change it? Do we need new exemptions? And when they issued their report at the end of 2006, not one member of the commission voted for this exemption. And they heard all these arguments over, you know, many, many, many lengthy meetings. And ultimately, the decision was made not to recommend this change. And then, of course, the General Assembly, through 2007, 2008, held special hearings. All these arguments were made then. And ultimately then, again, when a comprehensive revision to CON was passed, Senate Bill 433 in 2008, again, the arguments that multi-specialty groups should be able to get an exemption did not win the day. And I think it's because this connection was made that I'm talking about, this connection between the few profit centers that are so key to ensuring access to a wide range of services that are not available anywhere else and that nobody else wants to provide. And the very last thing I'll say is, you know, the idea that things have changed since 2008 is absolutely true. I couldn't agree with that more. Look at what's happened on the federal level with health care. I mean, I've never seen the amount of change, the amount of uncertainty, but the idea that the changes make it more appropriate to eliminate health planning for multi-specialty ambulatory surgery centers, I don't get that argument at all. I mean, the reality is, you know, the federal health care reform has reduced payments in many, many respects for hospitals and for physicians. But hospitals help to fund the Affordable Care Act. And a lot of the payments that hospitals have been receiving to help make up for some of the costs associated with uninsured and Medicaid patients that they treat are being cut dramatically. So the very goals, from the hospital's perspective at least, of health planning, which is to ensure the continued availability of these services, is more important now than ever, because we're about to see huge cuts in the amount of money that hospitals in Georgia have been receiving to try to make up for some of these costs. So they need these profit centers even more. They're more important now than ever to ensure the full spectrum of healthcare services remain available across the state. So that's the hospital community's perspective, and I'll be happy to answer any questions. Don't know if I'm not a CON attorney like Victor, but I'll do my best to answer any questions that you may have.
Forward, I'm going to limit it to 5 minutes because I have to apologize for people not being able to break for lunch, both members and people out in the audience. And so, questions for Temple? Let's see, Representative Watson.
Thank you very much for being here. And I certainly appreciate the history of all that. But, you know, the dramatic cuts that you're talking about disproportionate share?
That's right.
Right. That may or may not go away. Right. You know, the dramatic cuts may not be there. That's number one. Number two is the only way for the hospitals to be profitable. I mean, goodness gracious, what did Victor list? Real estate and income tax breaks, facility fee that you get 35 to 65% higher, whether it's an MR scan or ACS. You know, redoing on the federal drawdown that we just did here this year that Chairman Earhart mentioned. Critical care access hospitals, like rural hospitals, that get paid differently and higher. You know, goodness gracious, that's and then the mention about the way hospitals get sicker patients, that certainly is true, but there are also acuity levels related to the DRGs where you do get a bump in that. I don't know, I just, to me, the issue of quality of patient care doesn't seem to be driving either one of these conversations. I will say that, you know, the federal government through the ACA and ACOs, of which the hospitals have not been very receptive to, of which, you know, we have been trying to do, and hopefully successfully in the future. That's quality-driven patient care, and that's where driving down the cost of health care, whether that's through ACSs or whatever. I find that a little bit. You have a great delivery. But some of the statements about being dramatic in that are not, I just don't think jive with the facts. When hospitals talk about giving care, I mean, it is the EMT that Dexter Sharper is. It is the radiologist, the anesthesiologist. It is the physical therapist. It is the physician. I mean, when I come in the middle of the night to see patients, you know, in the emergency room where I'm on an ER assignment and I get no pay for that, and yet the hospital gets a disproportionate share for that, I don't know. I just find that a little bit offensive. I guess that's not a question. I apologize for ranting on. You can obviously see I have feelings about this, but thank you for being here.
Representative Kidd.
Thank you. A couple of brief questions. It sounded like what you were saying was that you wanted the hospital to be the entry place for patients that have an illness similar to the way a patient goes to a doctor's office. Is that correct?
I don't believe so. Maybe I'm not understanding the question, but I wasn't intending to make that point, if that's...
Does the hospital welcome patients, or can they accept a patient that doesn't go through the ER without a physician referring them?
No, yes, absolutely. I mean, hospitals can take referrals from...
All right, there's not a referral. I'm a patient. I walk into the front door. I'm sick. I need to be hospitalized. Can you take that patient?
Yes, of course. You go through
the staff physician have to refer that patient?
No, you've just shown up at the hospital.
You show up at the hospital.
Right, and in fact, you know, I didn't address actually 404, and if you don't, just very, very briefly, I'm going to make just a couple of comments about that, because I do think, you know, just FYI, I mean, the hospital community doesn't support any exemption to the health planning process, including any for our own members. The reality is I don't believe there's ever been an application for a freestanding pediatric emergency department or emergency facility. It's unusual because, you know, typically, as I said, the battles are over the profitable services when it comes to trying to get exemptions. But a couple of things just real quickly. One is about this issue of who has to, will we treat somebody that shows up? The Representative Stevenson asked about EMTALA and also licensure with respect to those facilities, so I just want to address that real briefly. One is that EMTALA, the federal law that requires that if a patient shows up at a hospital emergency department, the hospital has to provide a medical screening examination and stabilizing treatment. That only applies to hospital-owned. So to the extent that anybody else, opened for whatever reason a freestanding pediatric emergency department, they would not be subject to that requirement. And frankly, state law can't subject them to that requirement because there's no enforcement mechanism in state law. That's all on the federal level.
I wasn't referring to that aspect. My question was that outside the ER, how does a patient get admitted to the hospital? Outside the ER and outside a physician referring them?
They don't. Well, I mean, there are we have outpatient centers where people just show up.
Representative Kidd, help her out and tell her.
Well, what I'm getting at is that a patient's going to see a private physician, right? A private physician in his office or MSurg, wherever it might be, refers to the hospital because he's going to follow that patient in the hospital.
Right.
Patient comes to the emergency room. They're obviously, evaluated and/or hospitalized. If they don't have a physician, then it's your staff physician that admits them.
Right.
It sounded to me like what you were trying to say earlier, and maybe I heard you wrong, but that you wanted the hospital to be the entry point for health care and not the doctor's office or the MSurg office or the multi-special office.
No, not at all. I was not trying to make that point.
Thank you.
Representative Clark.
Thank you, Madam Chair. As a newer member who wasn't here for the CON discussions in the past, I'm sitting here trying to gain a proper understanding of this. You mentioned, I have a couple questions if I may, Madam Chair. I'll be quick. Okay.
Move along.
You mentioned that there was a couple year and a half study group, commission, what do we call it?
On the efficacy of CON.
Study group. And you said in the end, not a single member voted in support of
an elimination of certificate of need for multi-specialty ambulatory surgery centers. That was one of this same discussion that we've had today was one of the most contentious issues then as it is now. And, all these discussions took place and everybody made their arguments, and ultimately there was no one that voted in support of that from the commission.
Now, again, as someone who's new here is trying to understand, I thought that there was a compromise, though, that after roughly 30 years of CON laws, that I thought there was some compromise to allow.
You're talking about single specialty.
Single specialty.
Yeah, right, and that's different.
Surgical centers.
I mean, that's right, and there was a compromise. The hospital community, did make compromises. We did end up with a bill that expanded the types of single specialties that could open without going through the health planning process.
Come on, Temple. Let's be honest about it. The legislature forced it on the hospitals to accept general surgeons. It wasn't something that the hospitals agreed to.
Well, I mean, ultimately,
the legislature passed the law.
That is true, but we had many negotiations related to that, and ultimately, we agreed to support the bill, and that was in the bill. So, that was really where I was going. But that related to single specialty. ambulatory surgery centers. Again, these are small practices. They're usually just a few, physicians. And it's very, very different than giving an exemption to a huge physician group to open a multi-specialty surgery center, because you have many more physicians to refer patients to that center. So it's just a very different thing. And the hospital community has never wavered in the concerns that have been expressed regarding that. And every time it's been debated, ultimately the decision was made not to move forward with it, hopefully because of the concerns related to the linking of profit centers with the wide range of services offered in hospitals.
Second question.
Nothing further at this point. Thank you.
Representative Pack.
Thank you, Madam Chair. Quick question to follow up on what Dr. Watson was talking about in terms of profitability. For the states, and you may know the answer, I'm not quite sure, but for the states that, for the hospitals, for example, like HCA, who owns hospitals all around the country, for the states where they own hospitals where the CON law was repealed, two-part question. One, did they have to cut and close down any hospitals, number one? Number two, have they become so unprofitable that they can no longer operate?
And I don't know the answer to that. I will tell you that Georgia is a little bit unique because we have more uninsured patients than almost any other state. So when you look at states that have maintained health planning, it would be interesting to consider the issue of how many uninsured patients they have.
We have more than Texas?
No. I don't know about the percentage of Texas. No. I think there are only 3 or 4 other states that have more than we do, though.
Okay, so I guess the next group of people in the hospitals can answer this question when they come up. The organization owns hospitals in Texas. Had they had to shut down any hospitals versus the states when they operate when there are CON laws?
And I really have no idea.
Okay. Last question for Temple. Representative Henson. Michelle?
Oh, I'm sorry. I do have a question. Hospitals such as Piedmont on Collier Road, now they have a separate women's center, and I assume that's where all women who are having surgery go, or for gynecological issues or something. How many other hospitals set up where they have like completely separate operating rooms, which is sort of like creating your own outside center for the doctors?
I don't know how many hospitals have separate surgical suites related to women's services or other services.
Or different services.
Yeah.
I was just wondering, because I don't know if anyone else here from the hospitals can address that, because I know at one time we could have had that addressed.
Okay.
I just wondered about that. Thank you.
Okay, thank you, Temple. Okay, Jimmy Lewis. Now, as long as you're not going to come up here with a cross and skull, what is that thing, a skull and crossbones?
I haven't thought about that, but
yeah, right.
maybe going in
Not more than 5 minutes. And for the committee, when we were going through last time, Jimmy sent out to all his people the skull and crossbones and said all his little small hospitals across the state were going to close if we did CON, and gave us a hard time, didn't you?
I don't remember that, but if you say so, I'll defer to the chairman.
I got it in my file.
I'm Jimmy Lewis, and I head up Hometown Health, and Hometown Health is an association of 56 rural hospitals, and yes, we do talk about the issues. And to speak to a couple of points pertaining to that, I think first of all is to deal with profitability and the issue of profitability. There are two types of hospitals in rural Georgia. There are PPS hospitals and critical access hospitals. Critical access hospitals is a designation by the feds. They pay cost. And that's a problem because at the same time they pay cost, they also say that if you do anything to gain efficiency, you have to pay it all back. As a result, Madam Chairman, at this stage of the game, except for about 2 of 34 critical access hospitals, they all lose money and they're all on a subsidy-dependent basis to operate. The other type hospital is a PPS hospital, Prospective Payment System Hospital, and it has imputed upon it a payment rate of 85.6 that is a function of a state problem in about 1998 or 99, where the state at that time chose to deal with an economic issue by offloading the loss to a specific group of hospitals, and those are PPS. So they are, by mandate on Medicaid, paid 85.6% of cost. The type hospitals in rural Georgia that are that size are usually in the about 20 million or so range in net revenue, and as a result, most of those hospitals are losing substantial amounts of money as well. A symptom of the problem is the fact that in the critical access hospitals, because of the losses they have, 32 of 34 have quit doing OB. On the PPS side, there have been about 12 who have dropped OB, and there's another 6 to 8 that will drop OB because they can't afford to do it because of the pull-along factor of Medicaid that's associated with it. So those are some of the financial issues that are the premise for the problem that we have, especially when we look at multi-specialty clinics. Now, every rural community is not threatened by a multi-specialty clinic. There probably be 12 to 15 of those, and I look around the committee and I see a number of you who would be threatened with this particular kind of situation, because those are the hospitals that do indeed have some form of surgery that they provide, or they have people who come into the community and provide surgery that could be consolidated, and if they were indeed consolidated, they would take that volume out of the hospital. That hospital depends on it for a couple of different things. It depends on it for the ability to carry 7 by 24 capability. It depends on it for the capability of dealing with EMTALA, and EMTALA says specifically that if they show up, you take them. To the representative's point down on the end, when they show up, the point of entry, not through the physician, but the point of entry in the community, especially in rural Georgia, happens to be the emergency room, because that's where that's their point of access. So they have to deal with that being their point of access. So in those 12 to 15 communities throughout rural Georgia, and I do mean rural Georgia, and I'm talking about Swainsboro, and I'm talking about Sandersville, and I'm talking about Nashville, and I'm talking about Cordele, those are the kind of communities that would be threatened by this. It's a very real problem. I was just in Cordele night before last discussing this very issue with the CEO there, and he pointed out to me very clearly that one of the greatest threats he has is the coalition of physicians into what would be a multi-specialty clinic to take it all out. In rural Georgia, there ain't no competition. Okay, it's not a function of competition at all. It's a function of access, and it's a function of access through the dollars and cents that hospital can gain and can garner to keep its doors open. So the question is, for 1 million people in the state of Georgia, what is our position relative to access, and how do we maintain access, and particularly in those 12 to 14? And I would submit to you that in those 12 to 14, were they to be faced with the multi-specialty clinic, that they would certainly face the dire circumstances that have been described. And also I would point out that 3 weeks ago we did in fact close one. 2 years ago we closed one in McRae. We almost closed one 2 weeks ago, and Representative Black did a yeoman's job in helping us keep that one open. And we currently are working with no less than 6 that are enough cash fragile that they on any day may not make it. So it's a very, very real problem.
But none of that is due to a because since you can't have multi-specialty freestanding things, none of that, their closing, has anything to do with...
Those did not close because of multi-specialty.
Okay.
What rather they did do is they put them at a fragile state of 85.6% of cost. That the next step is the tipping point that will take the dollars and cents out of the community, and that's what they can't handle. So I would...
They don't exist now, so how did...
if this bill were to pass, for those 12 to 15 hospitals, they then would face the loss of those dollars that are surgical dollars in multi-specialties over to the clinic, that then would pull that hospital down to a very problematic situation. So I submit to you that in rural Georgia, with 1 million patients or so of our citizens out there, it's about access. In that case, it's not about competition, and it's about trying to preserve the access. And I would submit to you that this particular bill is critical to understand about the bigger scheme of things. Now, were those hospitals to be faced with multi-specialty clinics, and they did close or downsize, what that's going to do is ripple up to the next larger regional hospital, and that's going to create a major problem to your hospital or to a larger hospital that picks up the paramix. Briefly, and I'll close. The paramix in a rural hospital looks like this. It's Medicare, Medicaid, self-pay, and commercial. Okay. And the way that works is Medicare, you get to pull down about 95 cents on the dollar of cost. On Medicaid, you pull down 85.6% of the dollar on cost. On self-pay, you pull down 2 cents on the dollar of cost, and the remainder is in the commercial side. 50% of the hospital's payer mix is Medicare, 20% of it or so is Medicaid, 15% is self-pay, and the remainder is commercial. I don't need to tell you, but to start off to begin with, those typical rural hospitals are going to lose 10 to 12 cents on the dollar of cost before they start. this would exacerbate that problem and would create a much greater problem in the future for those hospitals.
Okay, Jimmy,
I thank you for the opportunity.
I have the first question for you, and I've been waiting a long time to give you a hard time about that skull and crossbones.
I do not remember the skull and crossbones, but to your point.
I have it.
Bring it on.
So, okay, I mean, that you went out to all your rural hospitals to call us. I got the calls. Okay. In all of these 12 to 15 rural hospitals, okay, I mean, when we're talking multi-specialist, we're talking a large group of physicians. How many of those small communities have enough physicians that could afford to spend the millions of dollars it would cost to set one of these up? How many of them have that many physicians?
There are 12 to 15 hospitals that do surgery.
No. I know that. But how many of those communities where those small hospitals that you think would be threatened, how many of them have doctors in all these different groups that all of them would want to get together and would have enough of them that could afford to go out and invest millions of dollars and compete with a hospital?
There are two populations that would be interested in doing that. There are the resident surgeons and others who would do that, and they can do that, and they would do that. And the other is the outside investors that would come in and populate that group to support them, and they're waiting in the wings to make that happen in a heartbeat.
Okay, and so there's enough physicians by numbers.
By numbers.
Okay. I mean, I know we're really desperate for doctors in rural areas, and I didn't realize.
Just these 12 or 15 who have the surgical capability and have the surgeons in those are the ones we're talking about. We're not talking about the other 45 rural hospitals.
Well, I mean, because I remember in the discussion of CON that the hospital said if we recognize general surgeons as a specialty where they could open up a single, specialty clinic, that hospitals all over the state would close down. And I remember in those discussions, it was said that it would take at least 4 general surgeons to even make one viable. And I think now, since that bill passed, there's only been 2 or 3 of those general surgeons get together, groups, and actually go out. And we haven't had any hospitals closed because we designated general surgeons as an area of medicine and specialty. Have you had an area where the general surgeons have grouped together and gone out and started one?
Not that I know of.
Okay. All right.
General surgeons. No.
Since we gave them that right in 2008.
I don't know of one, but that's not to say that there's not one.
Okay, because that was the big fear then. Okay, Representative Watson.
Thank you, Madam Chair. Mr. Lewis, it sounds like a wonderful place for a joint venture with those groups.
Probably would be.
Would be.
At the expense of the local hospital.
Well, the joint venture with the local hospital.
Remember in 2008 we gave the hospitals first time for the doctors and surgeons to get together, and as long as the hospital owed 30%, up to 30%, or you had to own 30% of it. And we gave them that ability to try to draw certain people and doctors to your area.
Okay, to your point, sir.
Yes, it just sounds like a ripe opportunity there for a free market to succeed. The Tattnall County Memorial Hospital in Reidsville,
yes,
a critical care access hospital.
Yes.
How much did it make a couple years ago?
More than a little.
More than a little.
Yes.
Number 1 in the nation.
Possibly, I don't remember the exact rating.
Front page of the front cover story.
That would be correct.
That's correct.
Yes.
How much?
I don't remember the number.
Over 20 million.
If you so state.
That's a critical care access hospital.
That's one in the state of Georgia.
That is Tattnall County, just not too far away from other hospitals that you mentioned.
That's
whether
correct.
that's Millen or Swainsboro, which is now level 3 trauma center.
Which one is that?
Swainsboro.
I don't know the
That's the one you called out.
Okay. So I know about Swainsboro, but I don't know the trauma level.
Thank you.
Okay, Representative Kidd.
To Madam Chairman and Dr. Watson, we're all on the same wavelength. In those communities where the hospitals have closed, would not this bill benefit the communities by the doctors who are still in the community forming a AMSURG center multi-specialty? Yes or no?
No, because the hospital probably would have survived for having been able to keep the volume, the marginal volume, in the hospital as opposed to losing it to the out to the AMSURG group.
The hospital's already closed. I'm talking about right now. Those communities where there is no hospital, let it close.
For those that have closed, for the most part, those are ones that didn't have surgery to start with and wouldn't warrant a volume or a demographic to support it.
Those that have closed for whatever reason, if the physicians are still in the community, be it 3 specialties or 2 specialties, could this not help the community by them opening up an M surgery clinic themselves in that community where there is not a hospital today?
Again, as I think back through the hospitals that have closed, there were not sufficient physicians nor surgeons then to support an AmSurg center, nor are there today physicians in that community that could do that.
Madam Chairman, I want to ask you more questions because he's obviously not answering this one.
Okay, thank you. I mean, I would just like to state that for the committee members that are new, when we did the bill, we did try to look toward helping hospitals also. I mean, one of the reasons that we allowed the joint venture was hopefully that it would attract physicians to some of your areas. If they had ability to make some money and stay in practice in rural areas that in combination with working with the hospitals, I mean, that was a move in CON to find a compromise that would benefit, you know, both our rural hospitals and our other hospitals too. So, I mean, we tried to make it not one-sided in that issue, and we were looking at the needs of our rural hospitals. Thank you very much. That was the last of the questions.
Thanks.
Dave Tatum.
Thank you, Madam Chair. I'm only here to talk about House Bill 404. I'm David Tatum with Children's Healthcare of Atlanta. Children's is the entity formed by the merger of Eggleston and Scottish Rite back in 1998. We also operate the Hugh Spalding facility for the Grady Health System, the Marcus Autism Center, and we've got 18 outpatient centers. We're also the only 2 pediatric dedicated trauma centers in the state, and our emergency services are the busiest pediatric emergency services in the United States. So when Chairman Earhart approached me about this bill before the session and then dropped it, it got our attention. We took it back, I took it back and met with our leadership, and I've shared everything I'm about to tell you with Chairman Earhart, and we mulled it over because we thought this might be something we'd be interested in. But after a lot of consideration and a lot of analysis, we have some concerns about it. We believe that from a quality perspective for the kids that would be seen, the physicians that staff this type of facility need to be board certified in pediatric emergency medicine. We might be able to pull that off at Children's. We're not sure if everybody got such an exemption, they would be able to do the same thing around the state, and that gives us a lot of concern. We also don't know what this is. Is this an emergency room that has a waiting room and some exam rooms? Or does it have an OR attached to it? If it doesn't have an OR attached to it, then do you have to make arrangements with your local EMS to send patients with a certain acuity to the main hospital and less acuity to your freestanding ED? Or if somebody comes in with a bad trauma, what do you do with them? And if you've got an OR, you have to have a very rare commodity in pediatric medicine, a pediatric anesthesiologist, and that's additional expense. Then do you have beds? What is this? Given those concerns, we cannot support the bill. I've also heard some talk, and I'll close with this, about private physicians perhaps operating one of these. And I think Chairman Earhart's right. I don't think you can, because this is an emergency department. It has to be associated and licensed with a hospital under current state law, under federal guidelines, under joint commission. And I don't think any third-party reimbursement entity would pay for emergency services unless it was licensed as part of a hospital. And for those reasons, we have concerns about 404.
I think that's one of the reasons that Chairman Earhart said and to me that maybe there needed to be more discussion on it, and if it was going to move forward, maybe it needed more fleshing out to talk about such a thing. But he talked about the pediatric emergency room doctors and that they would need to be run by them, to me, as he was leaving, and I agree with you.
Well, he and I have had that conversation. I'd be glad to answer any questions.
I don't have any questions for you. Thank you very much. Julie Wyndham.
Thank you, Madam Chair, members of the committee. My name is Julie Wyndham. I'm Vice President of Government Relations for the Georgia Alliance of Community Hospitals. On behalf of the state not-for-profit hospitals, I appreciate the opportunity to speak with you today. I'll begin with a few general comments explaining why we support CON. I'm sorry, I won't. You've heard all those comments already. I'll just jump to why we believe health care is not a free market regardless of CON, then talk about House Bill 279 and 404. You've heard here today the claim that CON would be more of a free market that healthcare would be more free market if CON were eliminated. We do not believe that is the case. Healthcare is not, and most likely will never be, a free market, regardless of what is done with CON. In most cases, your employer tells you what insurance company to use. The insurance company tells you which doctors you can see and what they will pay for a service. Your physician advises you on the services you need, and the government is the largest purchaser of services. All these factors prevent healthcare from being a free market. But perhaps the most important thing that prevents it from being a free market is that free market forces do not work without competition. While there is certainly competition for healthy paying patients, there is little to no competition for treating the uninsured and Medicaid patients or for providing essential but unprofitable services such as trauma, teaching programs, and neonatal intensive care units. For those reasons, we do not believe that healthcare is a free market, regardless of what you do with CON. Regarding specifics on House Bill 279, you are being asked to give an exemption from CON to multi-specialty ASCs. Keep in mind, multi-specialty ASCs can already operate in this state. They simply have to prove that there is a need for the services that they are providing. Therefore, Georgia's not-for-profit hospitals oppose this exemption. There are several reasons why we oppose this exemption. Multi-specialty ASCs would be allowed to have a number of EORs. While there is a construction cap, this exemption would essentially allow multi-specialty ASCs to set up surgery hospitals without CON review. The owners of these ASCs will get creative with the financing and find a way to build as many ORs as they think they can staff. We saw this happen a number of years ago with medical equipment when there was a cap on the amount of medical equipment you could purchase under the exemption. And we had several companies that produced the medical equipment create what they called the CON Buster package that came in just below the cap. We have no reason to believe that that will not happen here. Keep in mind that some hospitals in the state, in both rural and urban areas, only have 4 ORs. So 2 or 3 ORs is serious competition to that. We believe that these multi-specialty ASCs will hurt our ability to treat all patients by focusing their services on healthy patients who are able to pay for their care. According to the GAO, CMS, and MedPAC, patients treated in physician-owned specialty hospitals are not as severely ill as patients cared for in general hospitals. And according to a 2008 Health Affairs study, physicians refer 92% of privately insured patients to physician-owned ASCs and only about 8% to hospital outpatient departments. In addition, we believe that this bill would hurt our ability to provide essential but unprofitable services like trauma, residency, and neonatal intensive care units. As you heard earlier from Ms. Temple Sellers, the exemption for the multi-specialty ASC was thoroughly considered and rejected unanimously by the CON Commission. That comprehensive reform, as you've heard, was debated for 2 years and adopted by this General Assembly. At that time, we were told that ASCs that were given an LNR, or letter of non-reviewability exemption, would treat indigent care and Medicaid at a minimum level. However, according to the Department of Community Health's website, 52 LNR facilities have failed to honor their commitment to treat the Medicaid and uninsured populations and owe the state over $8 million due to that shortfall. That $8 million, if used to bring down federal matching funds, would be enough for the state to avoid the proposed 0.74% cut to providers in the FY14 budget. In addition, we don't know the full extent of what is owed to the state, as 176 of those LNR facilities are not reporting like they agreed to do, so we don't know the true impact ACSs have on hospitals. Now, DCH, is our understanding that DCH has been precluded from enforcing those provisions due to a lawsuit that has been filed against them. I'll take just a moment to respond to some questions that have been proposed.
And I have one for you, Julie.
Yes, ma'am.
I talked to people from DCH yesterday, and you talking about that they haven't reported in the $8 million. I was told by DCH that they don't know that, and if they don't think it would be anywhere near that, and you made it sound like you had that figure.
It is on the DCH website under their CON weekly tracking report.
Jesse, would you like to come and tell me why I got a different story yesterday?
Certainly, Madam Chair. Jesse Wethington, Director of Legislative Affairs for the Department of Community Health. As Julie mentioned, we have been enjoying, the department's responsible for operation of the CON program by the Office of Health Facility Regulation, and the Health Planning Division oversees that function. As Julie mentioned, we have been enjoined from enforcing most of the provisions around reporting and the minimum indigent charity care requirements established under Senate Bill 43 due to a lawsuit.
Why do you think that the ASCs might have, instigated that lawsuit? Why would they not want to give you the information?
I wouldn't want to speculate as to the motives of the ASCs for filing their lawsuit, respectfully, Madam Chair.
Well, could it be because they are private businesses and the hospitals are buying them up right and left, and if the hospitals knew how much they were making, they could go and cherry pick?
That would seem to be
Could
a
that
legitimate
seem
concern.
like it may be a good decision on, how much a practice is worth?
I believe that would be a legitimate business concern, yes, ma'am.
Okay, and I think maybe we didn't make it clear in the law whether they had to give that information. Might have been our fault for doing that. And it is posted on your website that,
Yes, ma'am, and that was provided to your office yesterday afternoon.
okay, are they the only ones, only the ASE are the only ones that owe the department money?
No, ma'am, we have facilities of various regulated types under the CON program that owe non-filer penalties for various reasons, for not submitting reports, not meeting indigent charity care requirements. That is a feature of most of the facilities regulated under CON that are characterized in that report.
Then they go into the millions of dollars for all these other agencies that...
I believe that's accurate. If I can, I'd like to ask my Director of Division of Health Planning to come and address that specifically if we can.
I'm Matt Gerard. I'm the Health Planning Director in the Healthcare Facility Regulation Division. I'm not sure where Ms. Wyndham, I'm not sure exactly where you got your figures, but I don't think it's $8 million from the CON exempt facilities. But I don't know the true number because we don't have good data from all of them for the reasons that Jesse spoke to.
Now, is that $8 million from the ones that we exempted?
The
Okay.
figure probably, excuse me, go ahead.
So if the legislator exempted them, then why are they even in the equation? If we said they don't have to pay it, why would we be talking about it?
I'm talking about the LNR facilities that were required since 2008 to have a 2% or 4% commitment.
Okay.
They've got to file financial data for
Okay.
us to evaluate whether or not they met their commitment.
Okay.
Those started coming online starting in July of 2008. So we don't have that many that have commitments. It's probably 20 or 25 or 30. And over the course of the next couple of years after 2008, more of them came online and had an active commitment. So we've got a group that didn't give us good data. We've got a group that gave us data. We've got a group that didn't report at all because of the lawsuit. So I think that the ones that we have good data from mostly met their commitment.
Okay.
It's the others that we're not sure about.
And so the others may be waiting until the lawsuit is settled?
Maybe.
And will they owe, if the lawsuit is settled in the favor of the state, won't they owe those?
We will pursue the shortfalls, yes.
Okay. Well, maybe if you don't win the lawsuit, maybe we need to come back with an estimate. If we can't get to the data, and the legislature would put an estimate on or something like that. But do we have other entities that y'all regulate? I saw the list last night, so I tell you, I know advance notice that there are lots of facilities that you regulate that owe the state lots of money. And I guess, why don't we collect that?
We're in the process of sending out shortfall assessment letters to the ones that you probably saw, so we will collect that.
But apparently this has been going on for years, and we have just let them not pay it?
We had the ambulatory surgery shortfalls because of the lawsuit. We were enjoined from using our enforcement authority, and we didn't have a full universe of data.
Oh, no, I'm not talking about those. I'm talking about the other kinds of hate facilities. And I understand there were hospitals on that, too, that didn't pay the fees that you assessed them. Is that correct?
A letter hasn't been sent probably to the ones that you saw, but letters are going out for those who have shortfalls, yes.
Okay. Has this been going on for several years?
Not several years.
How long?
2 to 3 years of
That people
a
owe us
backlog.
money in different facilities like nursing homes, hospitals, and other things.
Nursing homes don't have commitments. The hospitals who have shortfalls for hospital-based services
Okay.
were stayed from shortfalls because of the Provider Payment Act.
Right.
So hospitals don't usually have shortfalls, but to the extent that those who did, we could not collect on those shortfalls because of the Provider Payment Act. So we've got a few home health agencies, we've got quite a few ambulatory surgery centers, and we may have a few other types of providers that we will be assessing letters to get payments on.
Okay, so I wasn't aware of that. So part of the agreement with the hospitals in the provider fee is that that provider fee counts for their indigent care commitment.
That's correct.
So there could be hospitals around the state not seeing 3%, or what's the figure? 3% in indigent cares, but because they put the money up. Well, they're putting money up. Probably works out about the same. Seems pretty fair to do that. So they don't have to meet that other 3%.
That's correct.
Okay, but we are going to start collecting
Yes, Madam Chair.
from people that we know that owe us money.
Yes, ma'am.
Okay, thank you.
You're welcome.
Julie, I'm sorry it got to be that much of a...
No problem, Madam Chair. I will respond to a few other questions that I've heard from the committees if you've got time. The proponents of this legislation are right about one thing. Healthcare is in a state of flux, which means now is not the time to make this major change to our delivery system. They are also right that we are employing more and more physicians. A lot of times that's because the physicians are tired of the administrative burdens that are placed on them, and they just want to practice medicine, so they ask to be placed on salary so they can come and practice medicine and not have to deal with the billing and other administrative burdens. It's probably correct that on a per-patient basis, ASCs can charge less because they are usually only treating healthy paying patients. In response to the questions about how many states still have CON, according to NCSL, 36 states currently maintain some form of CON program, and the 14 states that have repealed their CON laws still retain some mechanism intended to regulate cost and prevent the duplication of services. With regards to Representative Henson's question, I don't know the exact number of hospitals with special service ORs or centers, but I do know if they have those, they would have to go through the CON process to set those up. Just keep in mind that hospitals provide many more services than ASCs do. It's just a different type of business model. Based on the 2010 study by Pershing Yoakley, for every $1 that we as not-for-profit hospitals are given in state and local tax exemptions, we provide $4 in community benefit. Unlike for-profit entities, we do not pay dividends or shareholders. We must reinvest any excess revenue back into the community and the services that we provide. With regards to House Bill 404, the sponsor is correct. The hospitals have applied for freestanding ERs. We have one member that has done so. They did so because they do want to open a freestanding ER. However, they want to go through the CON process to do that. We believe that this review is very important with regards to ERs, given the fact that ER overutilization is a major cost driver for the Medicaid budget and the healthcare system in general. Quality concerns are also raised given the lack of an OR backup for such a specialized service as pediatrics. In response to questions about EMTALA does not apply to non-hospital ERs. It only applies to hospitals that treat Medicare patients. And I'll leave you with one last thought. Weakening the CON program, we believe, will negatively impact the hospital Medicaid financing program. Senate Bill 24 raises almost $700 million annually by imposing a fee on the net patient revenue of hospitals. Over $450 million of that goes to providers other than hospitals, including doctors and dentists. Although it is unclear the exact impact that ASCs will have on us due to the lack of reporting, as we discussed, we do believe it will have a negative impact on the fees that are collected under SB 24. The bottom line is this. Do you want state policy to favor caring for all patients regardless of the patient's health status, economic status, or the services they need, or do you want to create a law that favors healthy paying patients with simple health care needs at the expense of everyone else? Be happy to answer any more questions, Madam Chair.
Well, I don't think that's exactly what we're looking at. I think we're trying to find a compromise where patients have choice and they can choose what's best for them, and our hospitals can survive, but also doctors who do not want to be hospital employees can have that option too, to function out in the community. So I don't believe that this committee is being asked to choose between those two positions, and I know as chair I'm not doing that. Representative Stevenson, you have a question.
I did. Madam Chair, I would wait until after everyone speaks. It's related to what Matt Girardi's already sat down. So
Okay.
I'll wait.
Representative Carl Rogers.
Thank you, Madam Chair. Julie, from what I can see from the hospital in our area, they do a great job. I think there's a disconnect now, y'all can agree or disagree, between our physicians and hospitals, mainly the ones that are not hospitalists. Do you agree with that as far as?
I think there certainly are issues, particularly in different areas. You know, in some communities, the physicians and the hospitals have a great relationship. In other areas, it may not be quite that great. I certainly agree with you that there is some tension.
What can the Alliance do to bring this to fruition, to have a doctor-hospital relationship and a hospital-doctor relationship?
Well, we actually looked several years ago at creating a component of our organization that dealt with doctors, particularly those that work in hospitals, to try and see if there were some areas where we could gap some of those differences. We've put a little bit of effort into that. Unfortunately, physicians are so busy these days trying to make a living, it's kind of hard for them to commit much time to that. But we've certainly looked at that and are happy to continue to try to do that.
Okay. So your group, you'll promise me you will work on that?
Yes, sir.
Okay. Madam Chair, I wanted to ask Mr. Jared a question before he got it down. Is he already gone?
Pam said who you wanted to ask questions.
There he is behind the post. Just clarification on your statement, the groups that owe the state dollars, did I hear you say y'all do it within the department, or are you subbing it out to someone?
We assess the shortfalls and collect the shortfall, and then it goes into the Indigent Care Trust Fund.
Okay. I thought you were saying you use someone else to do it.
No, sir.
Okay. So you do that yourself?
That's correct.
Okay. Thank you.
You're welcome.
Okay. Okay. Yes. Do you have another question?
Question. Now that you back up, what's the legal theory? What was the legal theory used by the AM Search Centers to enjoin the department? So I can understand why you're enjoined from collecting.
Well, there may be someone here who's an expert on the legal theory that they use, but they said that we didn't have the authority to collect what we were asking on the survey, and we were enjoined by Superior Court, and that was fought out over the course of 2 years.
Okay. And the reason I asked that question is to see if that 2% or 4% language was unenforceable, because right now it seems to be fighting. But you named 3 categories of ASCs, those that reported, those that were non-reporting, and what was the other?
Those that reported, those that were not reporting at all, and then those who gave us data that doesn't give us enough information to evaluate whether or not they met their commitment.
Those that reported, of the 20 to 25, how many reported?
I don't have the exact figure of those that reported, but of those who reported and gave us information that looked like it was valid, only a handful of the CON exempt ones had shortfalls.
Okay. Meaning they met the...
They met their 2%,
okay,
or 4% if they had it.
Okay. That was my question.
Okay.
Okay. All right. Thank you. That's all the questions, Julie. Thank you very much. Deb Bailey. Deb, if you can just not repeat everything that's been said.
Yes, ma'am, Madam Chair. My name is Deb Bailey, and I represent the Northeast Georgia Health System in Gainesville, Georgia. You've heard a lot of debate, and you've heard a lot of theory, and you've heard a lot about theoretical implications. I'm here today to talk to you about practical implications of giving an exemption to Certificate of Need for freestanding ambulatory surgery centers. In Gainesville, the Northeast Georgia Health System is a 560-bed not-for-profit community hospital. We have 261 skilled nursing beds. We have a freestanding psychiatric facility, and we are ran by a volunteer board comprised of community volunteers. Last year, the Northeast Georgia Medical Center provided $35 million in indigent and charity care. We provided over $16 million in uncompensated Medicaid. That is our actual cost of providing that service. That's not our charges. We're the third busiest emergency room in the state, and we have worked very hard to get this close to being a trauma-designated center, even though we've been treating now we're the sixth busiest trauma center. We're not designated. We're this close. This bill would jeopardize that designation. We are currently evaluating the ability to participate in the graduate medical education. Of course, as you know, that is also an underfunded proposition. We are very close to having that ability. This bill would jeopardize that also. We have the only neonatal intensive care unit in our area, and we're very proud of that. We have also been a major contributor to the Good News Clinic, the largest freestanding clinic in the state of Georgia, and have been since its inception. But all of these services that I have mentioned to you all lose money, every single one of them. So therefore, a hospital like mine requires some area of profitability. I guess you know by now what area of profitability that might be. Of course, it is surgery. If we are to continue to provide the services that we provide to our community, we do have to have some area that we make some money on. Our commitment to our community is to proudly serve the indigent, the charity, and the Medicaid. That's part of our mission, and it's part of who we are, and we do it very well. But in addition to that mission, our mission is to provide the highest quality of service to every single person that comes through our door. And thus, to that point, the Northeast Georgia Medical Center was named in the top 50 hospitals in the United States by Health Grades for 2013. Health Grades looked at over 5,000 hospitals nationwide for outcomes to choose Northeast Georgia Medical Center as in the top 50 hospitals in the United States. In addition, Health Grades, which also measures outcome for hospitals, in the state of Georgia has named the Northeast Georgia Medical Center #1 in cardiology for 7 years in a row. We are #1 in general surgery for our outcomes. We are #1 in gastrointestinal surgery, again for our quality outcomes. This is important because House Bill 279 and House Bill 404 would allow an exemption to the current law to allow for-profit entities to go across the street, pick off the last paying patients that we have, and our highly skilled, qualified staff. And who wouldn't want to go across the street and work the day shift, be off weekends, be off holidays, and work Monday through Friday? Most nurses would jump at that chance, and therefore, again, leave us in jeopardy of maintaining the highest quality of care in Georgia. We estimate in our community, if a ambulatory surgery center, a multi-service ambulatory surgery center were to open up across the street from us, based on our numbers, we think that it would cost our system $25 million. That's what it would cost our hospital. But what would it cost our community, and what would it cost our state? Our community would lose the highest quality surgical services in the state, not our designation, but Health Grades designation. In addition to that, the state would lose our contribution to Senate Bill 24, which is still substantial. And if you will recall, in that, as mentioned prior, and this was the only thing that I will repeat that's been said before, those funds we get back, the hospitals get back a percentage of that. But the physicians across the street were kept from getting a 30% cut for their Medicaid patients. And now they get to maintain their 11.88% add-on because of the hospital fee. And remember one thing, these same physician groups can go across the street right now and open a multi-service ambulatory surgery center. They just have to go through the certificate of need process exactly the way the hospitals do. Okay. In our community, you would find that there is not a need for that. I appreciate your time, your interest, and your respect, and I would ask that you please vote no on these two CON bills. I'll be happy to answer any questions.
Well, Deb, you make me proud. I've always said Deb was one of the smartest students I ever had.
And Madam Chair taught me psych nursing, and I just want to tell you it certainly come in handy down here.
And you at least brought up some new issues of high-cost areas, that is trauma, and we hope you'll come on as a trauma center.
We hope
but,
to.
But the trauma centers do have to have certain doctors on staff. And also, if you become and enter the medical education program, that is an area that hadn't been discussed. It is costly. Hospitals have to pay something. And the neonatal intensive care units. So, I mean, those are factors as we weigh this. So not to be biased one way or the other. I do realize that. And the quality that y'all are offering is, you know, outstanding.
It's
so,
top in the nation.
That makes me want to come back and live in Gainesville.
Come on.
It's like that. So, okay. We have questions for you. Representative Ben Watson.
Thank you very much for being here. And I too applaud you. I mean, Northeast Georgia Medical Center certainly has a great reputation, and I thank you, you know, for your status as nonprofit and the things that you do and that you outlined. I think that's wonderful. And let me tell you, you stepping up to the plate, the way that you have relating to residency programs that our folks down in Savannah have not. I'm going to applaud you. I mean, you are stepping out there. You're putting your money where you don't have to, and you're stepping up to the plate in the residency programs that are wonderful. And I must applaud you so much for that.
We are evaluating that program, but like I said, all of those programs are only as good as an ability to make enough money to put that money in those programs.
And you know, that is funded initially by your hospital for the first, 2 or 3 years?
Which part?
The residency program, residency
Not
stuff?
100%, absolutely not.
So you fund them up front mostly, and then after that, the federal government does help.
The federal government does help.
Yes, afterwards it does. And
Just doesn't cover the entire cost.
It does not. And again, I applaud you for doing that. I mean, the more residency spots we have in our state, the better we'll do. And I mean, I know one of our hospitals, you know, in Savannah does a great job of that. But I presume you had a lot of numbers otherwise. You had the numbers on the real estate and income tax breaks, or the facility fee that you do get, the 35 to 65%, or the disproportionate share that you get, or the how much drawdown will you or will you not get? And do you have the numbers on those?
I can easily provide you with those numbers, but what I would tell you is that in all of the studies that we have done in our community for the tax break that we get, we provide over $5 for every $1 in tax break
So that's
that we
the tax
receive.
break. The facility fee? The more, say, the numbers on the MR scans that you get paid more, the surgeries that you get paid more than the ambulatory surgery clinic, do you have any numbers on those? I think Victor said 35 to 65%.
I don't know that that's accurate for Gainesville. I'm sure Victor was maybe speaking for
No, that's Medicare fee, that's the Medicare rate, the facility fee. No,
Good, then those are, yes, then those would be the funds that we use to provide those services.
So you get Medicaid 85%, about 85% of what the actual cost is.
I think we figured about 82.5.
Okay, and the disproportionate share drawdown that y'all get?
We do. We get a percentage, but still the numbers that I presented to you earlier included the disproportionate share hospital piece that we received.
And the drawdown that we just voted on, do y'all get any of that?
No, sir. As a matter of fact, we lose money on that.
Y'all were losers on that?
Yes,
Good for
we
you.
do.
Good. I'm glad for y'all stepped up to the plate. Thank you.
Well, it's difficult.
Okay. Before you have a couple of more questions, I have to go for a meeting with the governor. I will not be discussing CON with him, so just put everybody at ease, unless he asks me a question if they've been watching what's going on over here. So before I turn it over to Representative Watson to run the rest, and to the committee, we're going to hear from physicians next. The question I would pose to the committee to think about, and I think one of the concerns that we have as the mega hospitals grow and there's less competition, and since hospitals do get a higher rate for all the reasons, that is a higher rate that we will pay for our Medicaid patients and a higher rate we will pay for our state employees. And we are now already having trouble funding that, with being $700 million short. So I think that is one of the things driving this discussion, is if we can't use ambulatory centers, surgery centers, and patients can't go to them where they pay less, and it costs us less as a state, you know, how do we ever meet that continuing growing burden that we've responsibility for state health insurance and for our Medicaid program? So I think that's something that will have to be discussed. And with that, Representative Watson, I'm going to turn it over to you, and there's 2 more questions for Ms. Bailey, and then we have, I think, 3 or 4 more presenters. And if I get a chance, I'll be back. If not,
Thank you, Madam Chair. We had a question from Representative Michelle Henson.
Is this on? Okay.
Yes, ma'am.
I think that the chairwoman answered my question about why you possibly might not achieve the trauma designation is because of the concern that the doctors would go to the ambulatory centers instead of staying with you, and you have to have certain doctors, certain specialties to be designated a trauma center. Is that correct?
Yes, it is correct that you do have to have certain trauma physicians to be designated. And we've been, and as you know, there's a shortage of those, and we've been in the process of, you know, with due respect of not gobbling up physician practices, we do have to try to hire some trauma surgeons to practice in our emergency room to be a designated trauma center.
So that's the reason you were saying that?
That we're this close.
Yeah.
We have hired one as of right now, and we're in the process of hopefully making that happen.
One other question. I can understand you referencing the groups in these other bills for being open Monday through Friday, 9 to 5. I mean, we look at ambulatory surgical center, but the bill that is presented by Chairman Earhart is calling it a emergency services for pediatrics.
I was speaking specifically.
Should it really be included in the same thing as a 9 to 5 Monday through Friday?
No, ma'am. You're absolutely correct.
Okay.
When I was talking about that, I was specifically speaking to HB 279.
Oh, okay, fine. I'm sorry, but I had misheard that then. Thank you.
Thank you.
Representative Carl Rogers.
Yeah, Dale, I just want to ditto what I told Julie a minute ago. And you and I, you do a great job for the medical center, and I commend you for that. But I think we still have a disconnect with the doctors that are practicing there, and now with the hospitalists coming into the medical center. The former CEO, who's no longer there, I think, caused a lot of friction. And the reason I know that, I got all the calls on it. So, but I would like to see not only our hospital or the medical center, but to reach out and try to work with them. I know we have a citizens board, but sometimes I feel like we need to bring some MDs on the board too. I know y'all do that, and you have a chief of staff and all that, but I wanted, you and I really hadn't talked about that, but I've been in our emergency room many a time, and they do a great job. So
thank you very much. And to that point, Chairman Rogers, I do believe that the Northeast Georgia Health System has tried to work with our physician partners, and I think the physician from Gainesville today would speak to that effort. And we certainly do have physicians on our boards, and they are volunteers also on these boards.
But I'm not referring to the present CEO, but the past CEO is no longer there.
That's correct.
Okay, thank you.
Thank you, Chairman Rogers. That certainly was a very delicate way of saying that with the former CEO, which I have no knowledge of, but I have some experience in the past with that. That's,
I'm still there.
Yes. Thank you. We do have another question from Representative Pack. Last question.
Thank you, Mr. Chairman. Some basic question. But following up on Chairman Rogers and Chairman Cooper's comments about the disconnect with doctors. If we were to foster competition, if we were to eliminate the doctors for a second, but allow other nonprofit hospitals to exempt them from going into your territory, what do you think that will do? So y'all compete on quality and price.
Well, I'm not sure that I understand. You're saying I am a not-for-profit community hospital, and so you're saying that you would give another not-for-profit community hospital across the street an exemption that I would not have?
No. Let's say, for example, it sounds like you guys have a great medical system up there, and I think Gwinnett, those of us from Gwinnett, has a pretty good one themselves. Right. What if we let you guys to provide some certain services in Gwinnett, and vice versa?
Actually, we are just a year away from opening a new hospital, very, very close to that.
You going through the CON process as well?
Yes, we did. And it's interesting that you might ask that, because we did go through the CON process to build that hospital down there. And even through that lengthy process, and we believe in the system, we'll only have 7 ORs down there, which is
Did Gwinnett Medical fight you off for it?
No, sir, they did not.
Representative Stevenson, did you have a question?
And thank you for your presentation. Of your total hospital revenues, what % would you estimate is derived from outpatient services, if you know?
No, but I can get that answer for you. I don't know the percentage. I know the breakdown of Medicare, Medicaid, but I don't know the breakdown of revenue from inpatient and outpatient.
Do you think it's over 30%?
I would think so.
Okay. And do you know of your outpatient services, what % is surgery?
I can't answer that in the exact number, but I can get those numbers for you.
Thank you.
You're welcome. Thank you very much for your attention.
Thank you very much. And we have 3 physicians that are going to testify. But before I do that, is Kathy Browning had signed up. Is she still here? Okay, so we'll move on to a physician that I know well, Dr. Pat Jones. If you'd come to the mic, is he still here? There he is. He's hiding. Okay, well then we'll go to, since Dr. Reinhardt's scheduled from Longstreet Clinic, Dr. Jeff Reinhardt. Would you identify yourself for everybody more so than I did, if you would?
Sure.
Thank you.
I'm Jeff Reinhardt. I am an OBGYN with the Longstreet Clinic. I'm president of the Longstreet Clinic right now. Some knuckleheads decided that was a good idea. I can't be happier than to have the opportunity to talk to you today, and particularly after Deb had a chance to talk. I stand here in front of you with my name tag proudly. It's my Northeast Georgia Medical Center name tag. They are my partner hospital. I feel very lucky to have them as a partner. As I've sat here today, and y'all's debate has been extremely stimulating. There's obviously we're going down the path where there's an obvious solution to this, I can tell. I say that in jest because this is such a complex problem. I'm struck by the fact that we've said very little about our patients, about the patients, about you as a patient, about me as a patient, about my children as patients. And we have a struggle that we'd like to provide the right care at the right time in the right place. And that's what this debate is about where is that place, and sort of to some degree when is that time. And a lot of the debate is stimulated by, or has been brought on by, stuff that's been out of our control. Our incentives, my incentives as an independent physician, as an independent business owner, are quite different from the mandate and incentives that Deb represents as a hospital. Now, there are places where we have partnered. I will tell you, the Longstreet Clinic has 98 physicians. That's roughly 20% of the physicians that provided that top 50 and top 100 care in her hospital. The NICU she spoke of is staffed with Longstreet Clinic neonatologists. The cardiology program, which has been #1 in the state, I don't remember, 7 years in a row, that care is entirely provided by independent physicians, not employed by hospitals. The GI guys in my community are all independent physicians. And what's happened here is that in an effort to align our incentives, we have found places we can work together, like providing physicians for the NICU, like providing physicians for the cardiac cath labs. And then there's places where we just haven't figured out how to do that very well yet. And in an effort to put that together, it's forced the hospitals to protect themselves and to purchase assets who have aligned incentives. Those assets are physicians. And so the employment of physicians has been done primarily to have one entity where everybody's incentives are aligned. It's the care of everybody. The Ellis Island of health care. Bring me your tired, your poor, your sick, your insured, your uninsured, your illegals, your neighbors, the people that are traveling. And that's the mandate that hospitals have. As a business owner, I don't have to have that same mandate, and there is the problem. The whole CON thing, and it's all surreal. This is all surreal to me, because the CON serves a huge purpose. In the state of Ohio, when they got rid of the CON, the number of ASCs in that state went up by 600%. Yeah, I know I represent this side of the room and not this side of the room, and so I said that, and they're all going, yeah, but that's reality. That worries me. That really worries me. Because if this law gets changed and that happens in the state of Georgia, that's bad. That acute the acute care hospital, the acute access hospital, critical access hospital that closed, that breaks my heart. It breaks my heart. What's difficult for all of us to put into perspective is the average number of patients who were in that hospital every day was 4.7 people. That's 4.7 people in a hospital trying to keep a building with radiology equipment, nurses, labs, IV poles. How do you do that? And there are numerous ones of those around that I can cite. If those places close, that whole access question that we were debating, that's a horrible, horrible problem. Horrible. How do you fix that? I'm not sure you fix it by changing CON. But I do think, And obviously it's beginning to sound like I have no idea which side of this argument I'm on. But obviously your debate and your questions make it clear that there's no right answer here, but we need to figure this out together. Together. And one of the ways you innovate and figure that out is to make the playing field level for us. By the way, we have no plans to open an ASC. None. We're the only organization in town that could do so, but you told me that I was going to make $25 million if I did. I have a meeting with the CEO this afternoon, our CEO. I'm going to tell her I'm opening an ASC if I can, because I'm going to make $25 million. We have no plans for that, and yet I'm standing here telling you we need to have this law changed. But it needs to make some sense. It needs to make some sense. We have to all play by the same rules. 70% of OB patients in this state are paid for by Medicaid. So that question, does that 2% make any sense to anybody? 2 to 4%, that's lunacy. It ought to be 20 to 40%. It ought to be based on the demographic of that area. It really ought to be. I implore you to continue to study this. I implore you to give me, as an independent physician, as an independent business owner, a tool that can help me solve this problem. But to perpetuate an archaic system like this, that's not going to get us anywhere. It's really not. Thank you.
Thank you, Dr. Reinhardt. We do not seem to have any questions. It certainly is a very positive and breath of fresh air that you bring. We hope to continue with this discussion. Thank you.
Thank you.
Will it be Dr. Davis or Dr. Jones? Dr. Jones, if you'd identify yourself for the rest of us here.
All right. Dr. Pat Jones. I'm a pediatrician. I'm the president of South Coast Medical Group in Savannah. And as an aside, as a pediatrician, 35 to 40% of my practice is Medicaid. I see Medicaid. Our whole group sees Medicaid, Medicare. Dr. Watson sees about 50% Medicare. So we're there for the community. We do the community. We're not trying to cherry pick. We take care of our patients. I want to approach this debate, and I'm in favor of 279, obviously, but I want to approach this from a little bit different direction. Everybody knows how much the cost of medicine is going up continuously in this country. It's out of control. And the reason behind this is because all medicine is siloed. You have the radiologists, you have the surgeons, you have the orthopedists, you have the internists, the GIs. They all have their own little surgery centers that work maybe 2 days a week. They're very efficient, but they're only open 2 days a week because nobody else can use it. That's the law, okay? So you have all these silos. Nobody can talk to anybody. It takes me 3 or 4 months sometimes to get consults back from like the neurologist or the GI guy because we're on different systems and nobody talks to each other. They're not integrated. And our group firmly feels that the only way that we're going to lower the costs is have coordination of care. And the only people who can do that are physicians, not hospitals. Hospitals have not been able to do it ever, and they're the ones that have the coordinators. The doctors are the only ones to do it, and you can only do it if you can talk to each other and everything works together. We feel so strongly, we actually formed one of the first 27 ACOs, accountable care organizations, in the entire United States. As of April 1st, 2012, we became an accountable care organization. This is an effort by Medicare to lower the cost of Medicare, and we're tasked to do that. We share in any savings, but our main purpose is to look at everything and integrate it together and lower the cost of delivering care. For the first time, as a result of being an ACO, we actually have seen data from CMS, the people who run Medicare, and it's astounding. This is the first time we've ever known that the #1 cause of admissions and readmissions to the hospital are UTIs. Amazing, amazing. Urinary tract infections, okay? come in with urosepsis. A lot of these are from nursing homes. They've been sick for a week, 2 weeks, and they come in, they're sick as dogs, and they're in the hospital for 3 weeks and go home. We looked at ER data. We have one gentleman, and this data is old. CMS isn't really up to date. This is like as of last September. He'd been in the ER 39 times in 6 months, every 3 days, for chest pain. Wasn't going to his PCP, wasn't doing any of those things. And one of the things that's increasing the cost, and what really brings my ire, is the nonprofit hospitals use their profits to buy physicians. And some of these places have 100 physicians. One of our hospitals in town has over 100 physicians. If you look at national data, hospitals lose between $125,000 to $200,000 per year per physician. So I kind of have a biased eye when they're sitting there saying, Chicken Little, the sky's going to fall down when somebody opens a surgery center, when they're losing that much money on all their employed physicians. The only one part of being the ACO and trying to do the accountable care is we have to be able to control all aspects of the care of the patients. And one of those aspects, and one of the high cost areas of that, is outpatient surgery. Unless I can control the cost at a low cost center, not a high cost center like a hospital, we're doomed to failure. We're not going to be able to do this. In order to do bring down the cost of medicine, it's going to take a real paradigm change. It's a real fancy word that people throw around a lot, but this is true. I've got to be able to control the cost. I've got to be able to know where they're going to go and know they get good care. It's the same doctors doing the surgery in the ASC as in the hospital, so they're good quality people, but I have to be able to have that function. And that's why we need the multi-specialty ASCs. We can consolidate and I think even lower the cost even more, because a lot of these little single entity, single specialty ASCs only operate 2 or 3 days a week. That's grossly inefficient. I just like to run a grocery store 2 days a week or 3 days a week. Okay? So we can combine several of those together into one and run that baby 6 days a week. We can lower the cost and provide good care. I'm open to any questions.
Thank you, Dr. Jones. And Representative Kidd waves. Representative Clark has a question.
Thank you, Chairman. Dr. Jones, can you help me understand? I think you mentioned that Dr. Watson treats 50% Medicaid.
Medicare.
Medicare, thank you. And I'm having a little bit of disconnect. I'm trying to put all these figures organized in my mind. The 2 to 4% that we were talking about earlier that they're required to care for, and yet it sounds like from your testimony and one other earlier that y'all are treating well above that?
Yes. I'm a pediatrician, so I'm going to be a lot heavier in Medicaid than most of the family, adult doctors are, okay? But within our group, it's a moral obligation that we treat each patient the same services, same everything, regardless of what level of funding they have, insurance, Medicaid, self-pay, whatever. We go our way, people self-pay to give them samples or to not charge for different services that we do so that they can afford to pay for this. We see a fair amount of those.
Thank you.
So just for the basics, Medicare is the 65 and older and disabled, and Medicaid is a state-run pass-through the federal government, would be more indigent related. And we have a Representative Wayne Howard has a question for Dr. Jones.
Yes, sir.
Thank you, Doctor, for your presentation. I want to just go back to Chairman Rogers' point earlier about doctors, physicians, and hospitals relationships, and maybe where some of the discord or may be. Can you offer anything today to us as to how we can the physicians as well as the hospitals can find that?
It's a difficult thing that we deal with every day. We have relationships with both hospital systems. We do things with both of them, and We need our hospitals. We're not trying to replace our hospitals. I don't want to run a hospital. I want nothing to do with one. But the fact that they're nonprofit, we're for-profit, so I pay tax. In fact, Dr. Watson is my partner for many years. We've been paying tax on incomes because as a good businessman, you have to have retained earnings so that you have the ability to expand and just maintain your business. And we've been paying taxes on money that we don't even receive. So we pay taxes. They take their nonprofit position and then use those monies to, the thing that irritates us the most is then they hire our direct competition. In fact, yesterday I was just notified that one of the hospital systems basically stole 2 of the doctors that are in our group. Our philosophy is the doctors make what they earn. We don't pay them anything extra. You want to work 3 days a week, you get whatever you earn. You want to work 7 days a week, you get that. The hospitals are willing to pay these doctors far in excess of what they really deserve for the amount of work that they do. And that is the main irritant between the doctors and the hospitals.
But so as we I'm 56 years old. I remember when doctors used to come to your house and, have the little kit and, get service right at your home or whatever. And I remember at the age of 13 having a bleeding ulcer and having an independent doctor, take care of me for 4 or 5 years to make sure that I was taken care of. So it's not always been this way, I don't think, just based off of my little history of hospitals and doctors. And, I just most recently had an experience in the ER where the ER doctors, diagnosed something, but I remember years ago when you went to the ER, they had to call your personal physician first before they did work on you. So so the whole industry has changed, I guess is my point, obviously. And as we go forward and look, down the road, I guess I'm trying to figure out in my head, where are we going and how do we make sure we keep patient care, which is what the OBGYN doctor mentioned earlier. Nobody talked about that. That's what it comes down to.
And that's our concern too.
Right.
Because, it really gets down to how much can we afford? How much medicine can you pay for? You're $700 million in the hole on Medicaid this year. Data from OMB, Office of Management Budget from federal government, study in 2004, and this came out of Jack Kingston's office. CON states have a higher cost of medicine per patient of $400 a year. Okay? That's, 2004, probably data from 2001, 2002. I'm sure it's almost double that now. So if you take 700,000 patients, multiply that by $800, and you're paying over $500 million a year more in a CON state than a non-CON state. Okay? That's why the CON issue really is so very important. I'm like the hospitals. If I had a monopoly, I would do everything I could to support that and keep that monopoly. But at some point, it comes down to how much money does the state have, does the federal government have to pay for health care? And that's why we're in this ACO. What they're trying to do, and we're right with it, and we see incredible opportunities to save medicine because we finally have the data. The doctors have the data. The doctors are the only ones that can do anything about this with coordination of care and collaboration with the other physicians and being in to where you can talk to each other. Before, it was illegal for us to have that data or even to talk about it. I couldn't even sit down to talk to anybody else about fee schedules or what they were getting paid or anything else. I get thrown in jail. Literally, the Department of Justice would come down and put me in jail, fine me tens of thousands, if not hundreds of thousands of dollars to keep us from doing that. So at some point, the question always boils down to is how much money does the state have to pay for health care, for Medicaid, and your state employees?
So I just like to I'm just dittoing what Representative Chairman Rogers is saying. If the physicians and the hospitals can find that middle ground so we can continue to give.
The hospitals do not want to have a middle ground. You're here in Chicken Little, the sky's falling, We're not going to go into any of the rural communities. The reason there are no single specialty surgery centers there because there's not the patient volume to handle it. We're businessmen. We're not going to invest $2 or $3 million in something that's going to lose money. So the single specialty surgeons, which can do it without anything, any work at all, why would a multi-specialty group go in some place where there's not enough patients to handle, to pay for it? So I think a lot of their arguments are specious. It's not going to affect the rural hospitals any, period. None whatsoever. If it was going to happen, the single specialty surgery centers of the surgeons would have already done that, and they just haven't done it because it's not viable from a financial standpoint.
Thank you.
Representative Kidd.
Thank you. Do have a quick question.
Yes, sir.
Years ago, prior to Medicare reimbursing for outpatient surgery, a local doctor here in Georgia, Harold McDonald, had done a private survey of his own patients, some that he put in the hospital, some that he treated in his office that had apples-to-apples diagnosis. Are you aware of any study that anybody has now that is semi-current of comparing the cost of the haves and the have-nots, so to speak?
Of the Medicare?
Or anything of their procedure?
Well, what Victor Maldonado was talking about earlier is the rates that he was saying, the 30 to 65% increase in rates the hospital give, those are Medicare published rates. Those are those rates. Those are set by the federal government, CMS.
Thank you.
Representative Henson.
Thank you. I just have a question. You talk about coordination of care by physicians and physicians talking to each other and getting reports back. Does Kaiser do that kind of thing, Kaiser Permanente?
Correct. If you look at all the big multi-specialty groups, Kaiser, Mayo, Cleveland Clinic, they're all integrated. They're all on the same EMR. They all look at the same data. If somebody does a chest X-ray yesterday, the results is in his chart. Now, in all these silos, if I see the patient here today, I do a chest X-ray, and they go somebody else tomorrow, they got to do another chest X-ray because they don't have the results of the first one. There's enormous amount of duplication in that order. So we see everybody's labs, we see everybody's X-rays, we see all the consults that they see, all the different people they see, when you're on an integrated system. And the only way you're going to do that is the doctors to collaborate. I have tried in our community to get the hospitals to create what's called a regional health information organization, where everybody integrates their own health data. And the hospitals flat refuse to do it. Not even interested.
It's interesting because following along your way of thinking of the coordination, I sort of wonder why DCH has never considered allowing state employees to have the option of dealing with Kaiser Permanente, and I don't know if anyone's still here from DCH.
I can't speak to that, ma'am. I just know from
I know you can't. I
from a
wondered if
personal
someone was
standpoint,
still
looking
here
at
from
what
DCH.
they pay, they pay less than Medicaid.
Jesse, you want to answer that, or you?
I mean, because I'm still getting complaints from constituents that they can't get back into Kaiser.
We're getting a little off track, but if you can just be real brief.
As am I, Representative Henson. We've heard from a lot of folks about that. For the committee's edification, a little bit of the history there. Kaiser was part of the SHPP panel up until 2009. When the current contract cycle began, they were not a selected vendor. We have a competitive procurement process that we do under the Department of Administrative Services reviews. We're currently rebidding that set of contracts right now. The RFP went out, I think, second week of February. So that's all, closed bid at this point, so I can't really comment on it directly, but I believe that company and many others are competing for that business.
But Jesse, what I've heard back then in 2009 was that Kaiser wasn't throughout the state, etc. I mean, it might not have been in the rural area, but certainly in all your large metro areas, and they've since expanded their network. So isn't the contract put out to bid every single year? You make it sound like it's once every 3 years or 4 years.
It's actually done once every 5 years, but the contract cycle is such where we annually review the contract with all of our vendors and make any adjustments. We do the same thing on the CMO side of the house.
So you're basically saying the Kaiser from 2009 had to wait 5 years to try to get back into the system. Is that correct?
Yes.
Thank you, Jesse. I sure appreciate that. Chairman Rogers?
Dr. Jones, I'm sorry, I didn't catch your first name and where you're
I
from.
go by my middle name. It's Pat.
Pat, okay. And you're from?
Savannah.
Okay. You seem to be real frustrated, tired of fighting.
This is, yes, I think this is the usual argument that the hospitals have. If you go back to this thing that they had in 2007, 2008, their committee, the DOJ, Department of Justice, from the U.S. Department of Justice, actually came down and gave them a brief stating that the CON system is bad, it needs to be dissolved, it increases cost, and decreases efficiency. Period. And I can get you a copy of that if you want.
I need a copy of that. I'd like to see that.
All right. And our big problem that we have is with the hospital systems when they get too big is you read that Wall Street Journal. That's what happens with their extra charges. They're not just a little bit higher. These charges are outrageous charges. Example, Monday, patient got insurance, goes to one of our hospitals, and unfortunately most people have large deductibles now. Everybody, $2,000, $3,000 deductibles. The hospital, you're supposed to have a CT of the head. Everybody knows what a CT is for the head.
I've had one.
Okay. They wanted to pay her entire $3,000 deductible as a deposit before they would do the CT.
Hospital it is?
The hospital.
Which hospital?
I'd rather not say. I know. They demanded her.
So there are only two hospitals in Savannah, three hospitals
Okay.
in Savannah, so
Okay.
two systems.
And even the insurance companies, so they called ours, and we did it for less than $300. Made her put a deposit, a tenth of that much. Okay?
How long have you been practicing?
I went to medical school, got out of medical school in 1976.
Okay.
So I've seen enormous changes.
So do you agree with what my statement earlier to the Alliance group that it's not a two-way street with doctors and hospitals? I know y'all been to medical school and you're bright, smart, probably not politically savvy, but
I will never, Ben knows I'm not politically savvy.
Okay.
I'm very straightforward.
Okay.
Doctors are very smart, they're very well educated, but they're very narrowly educated. They're not educated in business, by and large. They're not educated in politics. And you go into the hospitals glad hand you and all this kind of stuff, and they try to do anything. But the hospitals basically want to control everything. And the whole idea of them creating these huge networks that they employ at great loss, even if it's $100,000 a year, you employ 100 doctors, you just lost $10 million. And yet they scream Chicken Little that if we open an ASC, that everybody's going to go bankrupt. I mean, it just doesn't make any sense to me from a logical standpoint, a financial standpoint, or anything else.
how much longer are you going to practice?
I don't know. I'll be 66 this summer, so it's getting pretty frustrating.
Okay. Thank you for answering those questions.
And we do not have any more questions. We have one more person to testify. Thank you, Dr. Jones. We have Dr. Davis from the Harbin Clinic in Rome, Georgia.
Thank you very much. My name is Ken Davis. I am the CEO of the Harbin Clinic. We're the largest and the oldest multi-specialty group in the state of Georgia. We have 17 locations, most of which are rural. Last year we did about $15 million in indigent care. I'd like to state why we're here today and sort of give you a very short history as to why all of a sudden this law and others are important to us. The Harbin Clinic started in 1867. We have been serving Rome and Floyd County since that time, up until 1920 when we opened the first hospital in Rome. We did all of that care out of our offices. We had services like ambulances, which were horse-drawn. We did surgery in our offices, and we treated the indigent care. Everyone in our community was taken care of. In the early 1920s, we opened our own hospital. We, for 27 years, made money. We made money with an ambulance service. We made money with physical therapy and all the things that a hospital has to do. But in 1947, Floyd County Commission decided they were going to open a public hospital. So the physicians got together and said, you know, we should not compete with a public institution. We should close this hospital and support Floyd Medical Center. And so we closed the hospital. We helped found Floyd Medical Center, as we have also helped found Redmond Hospital. And we didn't do this because we were losing money. And we certainly wouldn't have done it if we had known that the hospitals were going to be in our business, recruiting physicians and managing physicians. We probably would not have closed that hospital. But we felt like it was the best thing for our community. We have a great relationship with our two hospitals. I'm not here to beat up on my hospitals. They are great institutions. We built our cancer center on Floyd's campus. Not only did we build it there, we put both Redmond and Floyd's imaging services in our facility so that the patients could get total cancer care, because we did not have the CON for a PET scanner. So we said, let's let them make the money because it's the right thing for our community. We started a PACS system in Rome, which is known throughout the country because all three institutions can share x-rays. You have an x-ray at 2 in the morning at Floyd Medical Center, a doctor can look at it at Redmond the next day and at Harbin. It stops that duplication we talked about. We were the group that helped that happen, and these hospitals have helped us in so many ways. The Georgia Cancer Coalition has touted Rome as the one community where they see everybody working together. I think that's really true. So I do love my hospital. I love both those hospitals. They're just outstanding facilities. And I will tell you, it angers me to no end to hear about this cherry picking. We were taking care of the indigent 80 years before a hospital showed up. 80 years. We continue to provide services that we clearly lose money. We spent $15 million on an electronic medical record. There's no return on investment. We have a diabetic center that costs us hundreds of thousands of dollars. We don't make any money off of it. We lose about $400,000 a year. We keep it open. The same thing with our clinical trials. We lose money, but there are 45 open clinical trials in Rome, Georgia for the people of Northwest Georgia, even though it costs us money. So why am I here? Well, things have changed since that CON study 7 years ago. The Affordable Care Act is here. We're going to have to be an ACO just like Dr. Jones. Our doctors are going to be at risk for cost. We will be at risk. And so where that person has surgery and how much it costs is very, very important. The second thing is the two hospitals are now recruiting physicians. That's my business, I feel. They have huge capital, one of which gets it from county bonds that I back as a taxpayer, and yet they're competing against me. Not sure how that's a fair playing field. They have access to unlimited capital, which we do not have. So all I'm asking for, and I'm not here to beat up on my hospitals, as Representative Dempsey knows, I support both our hospitals. We love our hospitals. We just want an equal playing field. We just want the ability for the Harbin Clinic to be there 150 years from now. Because when our competition, the hospitals for physicians, will pay $100,000, $50,000 more per year to their physicians, and then they will say, we'll forgive $100,000 of your student loans, that's a hard thing for us to pay for. we can't compete. So, again, I'm not here to bash the hospitals. As so many of you have said, we need physicians and we need hospitals. I'm not sure if you have physicians owned by hospitals, you have that, I'm not sure that's the system you have. I think independent physicians and hospitals can work together. Thank you.
Thank you, Dr. Davis. I sure do appreciate your insight and the historical perspective there. We have no questions from the committee. I think we've exhausted the questions for the afternoon, and this meeting will stand adjourned.